participant. To do the clinical research successfully, we should know the ICMR guidelines. That is very, very important. So, Indian Council of Medical Research, this is the governing body for us to do human research, the biomedical. So why these ICMR guidelines? So if you go back to the history, the atrocities against man to man, the Nuremberg Code came in the year 1947. It arose out of Nuremberg trials of Nazi physicians, all of us know, participated in cruel experiments on prisoners, the mentally retarded person and wounded soldiers during the Second World War. These amounted to torture, often ending in death. Among the experiments were exposure to extreme cold, submerging the person under the water for long periods, and exposure to poison and toxic substances. Another important landmark, the amendment, Kefauver-Harris Amendment in the year 1962 after thalidomide tragedy. The thalidomide, the drug was given for morning sickness in pregnant women in the year in Germany and United UK. In the year 1959 to 1961, the thalidomide tragedy, because this drug readily crosses the placenta and affects the fetus and produced cocomania, seal-like limbs. And if you go through the net, you can see the thalidomide families. So it produces severe congenital malformation. The carry-on message is no drugs should be given to the pregnant woman, only if it is necessary. It should be prescribed by the obstetrician and gynecology. There is no drugs because the placental barrier is an incomplete barrier. Any drug that is given, it can affect the fetus. Japanese vivisection experiments, which was conducted in American soldiers by so vivisection experiments was conducted. Tuskegee syphilis study experiment and Willowbrook hepatitis study done in mentally retarded children. So these have created the rules. The rules have been framed because of these bad incidents which took place. So this is another important for pharmacologists, especially for every clinical trials, the Helsinki Declaration. The World Medical Assembly meeting after this Kefauver Amendment, 1964, they set up a code of conduct known as Helsinki Declaration. This has been modified by World Medical Assembly several times, at least for 7 times approximately. And 1978 Belmont report came after this study. This is very, very important. The Tuskegee study of untreated syphilis, which was sponsored by United States Public Health Service, lasting from 1930 to 1974. 412 poor African American men with untreated syphilis were followed and compared with 204 men free of disease to determine the natural history of the disease. When the study began, the treatment available was not very effective. But research continued even after the penicillin became widely available. Here, the important thing you have to remember here, the subjects were not provided with information. There was no informed consent, and the study continued even after the highly effective treatment was available. So in 1980, from 1980, ICMR released a policy statement on ethical consideration and involved in research and human subjects and ICMR guidelines. So they are routinely, it is coming so even for the COVID-19, ICMR framed rules and regulations. So for us, the ICMR rules and regulations are very, very important for any person who do the research, clinical research. They have to know the general principles of ICMR. The first principle is principle of essentiality. The research being carried out should be essential for the advancement of knowledge that benefits patients, doctors, and all others in aspects of healthcare. And also, this is very, very important, it should not affect the ecological and environmental balance. So it also for the ecological and environmental well-being of the planet. Principle of essentiality is the first principle. And principle of voluntariness. The research subject or the guardian or the legally acceptable or authorized representative should be fully apprised of the proposed research. So the research participant should tell the research process, including the risk and benefit and alternate procedures available. Consent. Free voluntary, that is free informed consent should be obtained before the commencement of the research. The research subject has the right to abstain from the research at any time. Due care should be taken at all stages of research to ensure minimization of risk. The principle, this is very, very important, the principle of respect for autonomy is observed by informed consent. So that is in this auditory and video consent, nowadays they don't recommend, only in if there is if it is more necessary, then only it is taken. Otherwise, the written informed consent is mandatory. Only in vulnerable groups they can say, if the ethics committee or if they ask for the audio video consent, then it has to be taken. Principle of non-exploitation. The vulnerable groups with reduced autonomy. Third principle is principle of non-exploitation, such as students, employees, service personnel, and prisoners may be involved in research only if there is an adequate justification. Their vulnerability should not be exploited. The rights and welfare of the mentally ill or mentally retarded should be protected at all times. The person who are economically or socially disadvantaged should not be used. Next principle, principle of social responsibility. Research should not disturb social harmony in community relationships. Fifth principle is principles of ensuring privacy and confidentiality. The identity and particulars of the research participant and the research data should be kept confidential. The thesis, the research data may be disclosed only for valid reasons. One is when it is of court order, legal reason or scientific reason. And with the consultation from the IEC, Institutional Ethics Committee, then only the identity and the particulars of the subject of the research data will be given. For two reasons, one is the legal reason, other one is scientific reason. Principles of risk minimization. Due care must be exercised at every stage of the research. The research participant should be subjected to minimum risk and should not suffer from irreversible adverse effects. Seventh, principle of professional competence. The research should be conducted only by competent and qualified person. Please remember, it should be done by competent and qualified person, and research must be conducted with integrity. Principle of maximization of benefit. The research should seek to maximize benefit to the research participants and society. The participants may be paid for time away from work and reimbursement of expenses incurred. The participant may also receive free medical services during the period of study. Payment should not be large. Please remember another important point, so as to induce the subject to participate against their better judgment. Compensation. The research protocol shall include the mechanism for compensation through insurance and other appropriate means to cover all the risk and to provide for remedial action and aftercare. This is another important point. It should be there in the protocol. The brochure should contain everything, the compensation, particularly for the clinical trials. The principle of institution arrangements. The institution involved shall make all necessary arrangements for the proper conduct of research, storage, and use of the data, and for ensuring confidentiality. The complete records of the research should be retained for reasonable period for post-research monitoring and evaluation, at least for 3 to 5 years. Principle of transparency and accountability. The research should be conducted in a fair, honest, impartial, and transparent manner to generate accountability. Related records, data, and notes should be retained for the required period for possible external scrutiny or audit. The results of the research, whether it is positive or negative, it should be available to the public. The information given should be accurate. It should not raise false hopes or expectations. 11th principle, principle of totality of responsibility. All stakeholders, the researchers, the sponsors and funders, the institution where the research is conducted, those who use the results of the research, all persons involved directly or indirectly in the research or responsible in the research or responsible, they have to know. For this, they have to know and practice the guidelines and regulations framed by ICMR. The last principle, principle of environmental protection. The researchers are accountable for ensuring protection of the environment and resources at all stages of research in compliance with existing guidelines and regulations. For example, if they are using any biological samples, it should be disposed, the biomedical waste should be disposed properly, the drugs should be disposed properly, it should not affect the ecological balance. So for this, to conduct the clinical research, another important governing body is ethics committee. The institute should have institutional ethics committee. The properly constituted ethics committee shall look in all ethical aspects of the proposed research on human subjects. So our institutional ethical committee, the last registration was done in the year 2019. So now they have given permission up to 5 years. So these are the principles. These principles should be followed strictly while doing clinical research on human beings. To conclude, the modern medical advances for the span of 50 years, so science and technology, the medicine and technology have developed very much, and it has helped the modern medicine. That is the importance of modern medicine when compared to alternate type of medicine, alternative system of medicine. Everything is evidence-based medicine. So it has helped millions of people to live longer and healthier lives. If you go through the history, if you see, now we have wonderful anti-hypertensive drugs. Previously, we used to see so many strokes, paraplegia, quadriplegia. Now the incidents have come down. Another important thing is drugs used in peptic ulcer disease. Previously, there were many preparations, bleeding, everything because of the wonderful drugs like proton pump inhibitors, H2, all because of these modern medicines and because of the clinical trials. And we have to thank profusely the participants, the researchers, the volunteers, and the patients who took part in the clinical trials. They are the root cause for this improvement, and we owe these improvements to decades of investment in medical research. So many wonderful drugs like low-dose aspirin, statins. Therefore, these drugs prolong the life of they increase the lifespan of the patients, and also to live in a healthy way. The pharmacology, the drug is very, very important. The pharmacology, again and again, I'm telling you, the pharmacology is one important subject, one of the important subjects which bridges between physiology and pathology, so that the researchers should have sound knowledge in clinical, the principles of general principles involved in general principles that were framed by the ICMR, and also they should have sound knowledge in pharmacology, so that the clinical trial will be very much successful. So with this, I conclude my talk. Thank you very much. Thank you, Dr. Melanie.
Yes, ma'am. Thank you, ma'am. So now the floor is open for questions. If anybody has any questions related to the general ethical guidelines for biomedical research, or any other question related to ethics. So, of course, ICMR has brought out a guideline for doing clinical research in 2017. It's a very detailed document. You would require a full day to even just go through it and discuss the whole document. So it is not possible to go through all those details in a short workshop like this. So, but still we are open to taking any questions related to ethics now. So we have around 10 minutes left for the next session. So if any questions from anyone, we'll be happy to take it. Okay, there's one question about the approval, for registration of ethics committee, the duration of approval, it says 5 years time. Is it for all or duration of approval? So essentially, this approval, ma'am, the question is about the validity of approval for how long it is.
5 years. Now recently they
Yeah.
have previously it was
Yeah.
5 years, now it is 5 years.
Yes. So it's, as ma'am said, it's now 5 years. So this is for CDSU registration. If you are if you're having an ethics committee and that ethics committee is reviewing clinical trials, then it has to be registered under the CDSU in New Delhi, and the registration is valid for a period of 5 years. Biomedical and health research, does it include clinical trials also? Yeah, ma'am, you want to answer that question?
Biomedical?
Does biomedical and health research includes clinical trials also?
I think yes, sir.
Yeah. So more or less, biomedical and health research is a very broad term. It includes everything under it, including clinical trials. But the the distinction that you have to make is uh, clinical trials which are regulatory in nature. The clinical trials wherein the data is submitted for the purpose of marketing to CDSCO, that cannot, such a clinical trial should be reviewed by a committee that is registered under CDSCO. Only a committee that is registered under CDSU can review regulatory clinical trials. But if you're doing an academic clinical trial, let's say you're doing a PG research thesis and you're taking a drug and you're evaluating that, and this drug is already in the market, so but you're trying it for a new indication, then it becomes an academic clinical trial, provided the data is not going to be used for marketing after the trial is over. At the end of it, you will be publishing it in a journal, and the scientific community is going to know about the results of that study. So that becomes an academic clinical trial. Such a trial usually does not require a review of a CDSU registered ethics committee. It's enough if the committee is registered under the uh, uh, Department of Health Research. So there is another registration process that is there for all other committees. That is the Department of Health Research. So Department of Health Research, New Delhi, registers again ethics committees in India for all biomedical and health research. So, is there any government clearance or permission required for collecting samples from public places? For example, water or river or soil samples. So, to the best of my knowledge, there is no permission per se, unless the particular place from where you're collecting is something, an environmentally protected area. Then you might have to go to the local authorities, Ministry of Environment. Suppose it's an endangered species area or some restricted area, which is like reserve forest. In all those cases, you might have to get the local permissions, but otherwise I wouldn't say that you would require any permission for collecting publicly available, like a soil or a sample from a river or something like that. But you could check this, because this doesn't deal directly with humans, so you could still check this with others. And how much time is okay between research and publication time? Research done today can be published anytime in future or any set duration. So, ma'am, you want to take this question? Like, the question is, suppose I
It is
finish
up
a
to once. So yeah, they have to see because of the time is if someone publish it before the, they
exactly,
have to see
exactly.
whether
Yes, exactly. As ma'am rightly said, if you wait a long time, all your hard work is going to go down the drain, because by the time, if you wait for 1 year after you publish your finish your research, by the time somebody else might publish it, so then the person, the researcher, is going to be the one who's going to lose. So it's better to reduce the time as much as possible, not wait for too long. But there are instances where sometimes research, for some reason, it could not be published immediately, and then practical difficulties, because of it is being attempted to publish after 2 3 years. Whenever you're doing that, you please mention that very clearly to the journal that you are sending it for publication. Do not try to change the dates. Please make it very clear that This was done in 2016, but however, for some practical difficulties, it could not be sent for publication to any journal then. So it is being sent now. So yeah, it's important that you explicitly tell that. But do not delay when there is no real reason to delay it. Yeah, any other questions? How can we get ethical approval for independent researcher? So for independent research, for research that is where you are doing it as a, maybe you're a clinician, you're doing private practice, you're not affiliated with any local institute, or your hospital does not have its own ethics committee. In all such situations, you would have to go to the nearest hospital having an ethics committee, speak to the hospital authorities, the ethics committee member secretary preferably, ask them if they can take your proposal in their next ethics committee, and whether they are willing to review your project and take responsibility. Because the minute they give a review of your project, it means that they are willing to take responsibility for all the patients who are part of your study. So you need to contact the nearest ethics committee from your clinic or the place where you're going to do research. And that ethics committee, if they are willing to review it, then there is no problem. Of course, that ethics committee should have an SOP stating that they will be allowing even outsiders to present their proposals. Does ethics committee permission needed for research in public health? Of course, yes. So public health is not something that is out of the ambit of ethics committee. Even if it is a public health related research, ethics committee permission is mandatory. Which studies do not require ethical clearance? Ma'am, you want to answer this question, ma'am? Which studies do not require ethical committee clearance?
So in vitro studies, or
Yes,
microscopic
exactly.
studies.
Yes. So as ma'am
Have to
said,
get the permission from the hospital authority.
exactly. So the thing is, there are a few studies. You can go back and read the ICMR guidelines. It classifies studies into less than minimal risk, and more than minimal risk. So the ICMR guidelines, it tells you that. So essentially, if your study is something that is collecting data from a publicly available place, meaning like the research, the data is already available in the internet, it's publicly accessible by anyone. So then the question of getting ethics committee permission may not be required. Like you're doing a meta-analysis, systematic review and meta-analysis. You're just collecting data which is already available, freely available to anyone in the public domain. So in such situations, you can go ahead. There is no need for ethics committee permission. If you're doing any study which does not involve humans and does not involve even animals, okay, no living system like in vitro studies, then you could go ahead and you can, but even there are committees which say you should apply for waiver of consent, apply for waiver of review, but they might, again, some ethics committees might say we would like to review the project for its scientific merit. So if the ethics committee says that yes, we want to review it in your institution, then you will have to submit to ethics committee. Ethics committee might not take it up for detailed review, but they might still go through a scientific review. Or some institutions might say it is enough if the scientific committee approves this project. It's in vitro research, so we do not want to send it to ethics committee. So it changes from institution to institution. But essentially, in vitro studies done where the data is from publicly accessible information, where you're not taking the individual information from any patients, any data. In all such situations, you could you can avoid going through the lengthy ethics committee review process. And whenever there is a doubt, okay, it is better that you submit it to ethics committee. Do not assume that your research is such that it does not require ethics review, because sometimes we might be mistaken in that. In fact, ICMR guidelines tells very clearly that the decision whether ethics committee is required or not should not be taken by the researcher. It should be submitted to ethics committee. The ethics committee member secretary is the one who is supposed to say, this does not require ethics committee approval, so you can go ahead and do your study and start doing the work and publishing it. Okay, I think we'll take one more question and then we'll go to the next session. What about case report and case series? Nowadays, case report and case series. Ma'am, you want to answer this, ma'am? Do we need ethics?
Yes, for publication purpose, they request the approval from the ethics committee.
Yes, exactly. So, as ma'am said, ethics committee permission these days is increasingly being asked by many journals. Many journals are expecting that as part of the guidelines, that the ethics committee should have approved the project, approved the case report for publication. So, it is better you get an ethics committee permission before you submit it, because most of the good journals are asking for it. Okay. So there are some more questions I understand. We'll take it during the Q&A. So now I'm going to introduce the next speaker of the day. Dr. Smita, are you there?
Yeah, Dr. Melvin. Yeah, good morning, everyone.
Good morning, ma'am. So I'll just introduce you to the delegates. Welcome, Dr. Smita. So Dr. Smita is someone that's familiar with us because she's been part of our workshops before. Dr. Smita was in fact part of NCRM 2019, where she had come physically from Chandigarh, and then of course in EPCON 2020. And she's here again with us this morning to speak on how you plan when you do a research, how do you plan for the research? How do you identify a good research question? So Dr. Smita is an additional professor of pharmacology at PGIMER Chandigarh. She is a life member of IPS and of the ISRPT, and she's a member of National Academy of Medical Sciences. She's a member of American College of Clinical Pharmacology and a member of International Association of TDM and Toxicology Immunosuppressive Drugs Committee. She's an editorial board member and reviewer of many prestigious journals such as British Journal of Clinical Pharmacology, Journal of Cardiovascular Drugs and Therapy, Journal of Pharmacology and Pharmacotherapeutics, International Journal of Basic and Applied Medical Research. And she has won several prestigious awards, including the Eagle Eye Award from the editors of Goodman and Gilman's Pharmacological Base of Therapeutics. She has been awarded the prestigious Fulbright Nehru Academic and Professional Excellence Fellowship in 2014-15, full scholarship for Global Clinical Scholars Research Training by Harvard Medical School, Boston. And she has attained a distinction for the capstone proposal in Global Clinical Research Training Program by Harvard Medical School, Boston. And she's awarded the Best Researcher in the category of Assistant Professor in the Second Institute Foundation Day Research Acquisition Program 2013. Her research areas are mainly in clinical pharmacology of immunosuppressants and anti-cancer drugs, therapeutic drug monitoring, model-informed precision dosing and pharmacogenomics, clinical research methodology and biostatistics, clinical pharmacology of drugs on genitourinary system, drug repositioning in cancer chemotherapy. She has enormous number of projects and publications to her credit, and she's guiding training program for MD, MSc, and DM in PGI Chandigarh. And she's also executing a few investigator-initiated projects as a PI, funded by intramural as well as extramural funding agencies. So she's a very accomplished researcher and distinguished researcher who's been part of our programs in the past, and we are very happy that ma'am could make it for this meeting. So please, over to you, ma'am.
So, Dr. Melvin, I should start sharing my screen?
Yes, please. Yes, please.
Yeah. The issue is my video is not working, so I will have to manage like that.
Sure, sure. No problem.
Okay. And so give me a sec. Just stop. So, just a minute. Sorry, Dr. Melvin, I just have to press share screen, right?
Yes, yes. Please click share screen and you'll be able.
So somehow it's not accessing. Oh, I got it now. Okay, thank you. Okay. So can you
Yes.
see my screen?
Yeah, we can see it. You can probably put it on full screen. Yes.
Okay. Okay. So there we go. Okay, so as good morning students, good morning everyone, and let me start without much ado. Already Dr. Melvin has listed a lot of things, but the basic thing is everybody starts somewhere. So I also started 20 years back. That was as an MD student, where we start to develop. We begin our journey to understand how to conduct research. So that's where I will start now, because this is where all the participants are starting, hopefully. And I had sent a couple of questions to you, Dr. Melvin, for
Yes. Shall
sort
I
of
launch it?
understanding the. Yes, yes, please do.
Yeah, please click on the options that are provided to you. We'll give you 2-3 minutes to answer this.
Okay, shall I read all of you? Have you drafted any research protocol or submitted any for an approval of the Institute Ethics Committee? Just say yes or no so that I'll understand how many of you are kind of a little experienced in terms of this endeavor of yours. And what was the most difficult part of planning a research study for you? Finding a good research topic or an idea within the limits of the logistics, finding a research collaboration for on a workable research idea, inadequate specialty knowledge to draft the research design, or inadequate skills to execute the components of the study, such as randomization and allocation concealment, blinding, etc. Okay. So can we have the next to Dr. Melvin?
Ma'am, I think people can see all the questions. Are you able to see all this?
I am not. Okay. Okay. Sorry. I'll have to scroll.
Yes.
Okay. So third question is, have you completed any research studies? Yes, no, or it is ongoing. Then, or no is essentially no, or no, it is ongoing. So the fourth question is, if you have completed a research study, have you analyzed your research results? It is either yes or no, or I haven't conducted any study, so it is not applicable to me. Now, the fifth one is, you have already completed the analysis of your study results. Have you attempted to publish this? So it is again the same choices as the above question. Then question number 6, those who have sent it for publication, in the process of peer review, what are the major challenges that you faced? The peer reviewers, did they say that you have chosen a more meaningful research question, or your study design is not appropriate, or is there any problem with the analysis, or your manuscript writing skills need a little grooming? Then it's not applicable. It's not applicable to you. Okay. Now the seventh or last question is, what are the skills that you would like to improve as a researcher? Learning to ask the right question, making best use of the available resources to execute a research idea, equip yourself with the knowledge and the skills needed to design an ideal study for answering a research question, or learn the application of statistics in designing and analysis of your study. Learn the scientific writing and the art of publishing. So I hope people would have taken some time. They would need at least 30-40 seconds more to complete this.
Yes, yes. Around 46 have already filled. So
Okay.
others are filling. So I think
Oh,
another half a
right.
minute they'll be finishing.
Sure, sure. It's a very nice endeavor, Dr. Melvin. One needs to take any Zoom training sessions or what? I am amazed with your skills of handling it.
Thank you.
For me, I tried to log in from the browser as well as from the app, but
Okay.
somehow Sometimes the video gets switched on.
Yes, yes. There are some issues sometimes with some
I
browsers.
I fail to understand that, but I think we can manage without that. I really miss those classroom teachings actually,
Yes.
which connects the student in a different platform. Like it's one-on-one, eye-to-eye interaction is something I really hoped that my video will work, but it somehow failed me.
I'm
Never.
79%. 54 have answered, so I'll end the polling here.
Okay.
So I'll just show it.
Okay. Sure.
Yeah, you can see the results.
Okay. Right. So about 50% of them have already, I mean, they are experienced, and 50% are planning, I believe. Most difficult part is finding a research question. 13% also feel that collaborators are difficult to find, inadequate knowledge, or that is very much doable, and inadequate skills to execute. Correct. So I am very happy to see this because the option number 3 and 4 are actually pretty much you can build on them. I mean, you can always improve them. You can always, I mean, it's everybody goes through that learning curve. So that is, so 40% of your problems are solved here. Now, I completely agree with all of you that finding a good topic or idea for research within the limits of the logistics is the bottleneck. And about the second option, finding a research collaborator, this is again a skill, and possibly that can be also honed over a period of time. You need to know how to talk to people and how to give them a research idea that they would like to buy. I mean, I am talking in terms of as if I'm an MBA who is selling his product, but yes, it works like that only. You have to present a research idea to a collaborator who finds it pretty much interesting to collaborate with you. So a, a statement or a gesture of mutual benefit comes, and yes, sometimes there are some genuine issues, but many a times this is a skill that we need to develop also as a researcher. So again, finding a good research topic with the limit of the logistics. Okay, so we all are struggling with this. The in greatest of the research settings also people struggle with this. Okay, and now the third question, have you completed any research study? Okay, I am so glad to see that 40% have already completed the research, one of their research studies. Have you completed the study and analyzed the results? Oh, that's also again great. About 36% have already done some research, and out of these 42, possibly 36 have already analyze the results. So if you have already completed your analysis, then have you attempted to publish? Okay, so around 30% have also attempted to publish. That's also another encouraging thing. So those who have sent for publication in the process of peer review, what are the major challenges? Okay, so the major challenge they find is manuscript writing skills, and that needs a little grooming, and not applicable is 58%. That means that people are haven't yet attempted that. Okay, and it's pretty much encouraging that 26% and 58%, but this 58% tells that people have not tried to send for peer review. Okay, so the last question. So everyone thinks, I mean, almost large majority thinks that equip yourself with knowledge and skills needed is the most important thing. Completely agree with you. And second best is the application of statistics and in terms of design and analysis. That's also important. And unfortunately, I do not see the first step that actually pertains to my this talk is being marked. So that makes another good ground for me to pursue with this lecture and tell you the importance of asking the right question. So everything starts, I believe, here. Yes, skills and knowledge that can be acquired. But having said that, we have to start somewhere. So the starting point is the right question. Then in the process, we acquire all these things and then move ahead in our research career. Right. Okay, Dr. Melvin, I'm very happy with the responses, and it certainly provides me the real interest it generates to go ahead to, because I understand that okay, the skills are important. I want to emphasize the skills are definitely important, and in this era of internet, acquiring skills is not as difficult as where people were studying from textbooks and looking up to mentors. Yes, mentorship is important. Having said that, I would presume asking the right question is where we start. And when we ask one wrong question, and or we ask one question which has got little less relevance or not contemporary or has already been done by someone, and we face problems in publishing that, people asking what's new in this, what's not, what it is adding to the current scientific literature, then we go back and see what was wrong in our methodology. So basically it is a two-way process. You go forward and then you go take a few steps backward to understand your own errors and mistakes and improve upon them to further ask a better question. That's where again you start. So it's basically an iterative process, I would say. And as a postgraduate student, we always start with a thesis, which is nothing but asking, planning for a research, studying and executing it, and then compiling it, and then presenting it as a for the partial fulfillment of our degrees. Right. So there we go. Okay, so this I have already done. So what are we going to learn here? So what we are going to learn what is a research question and what is a research hypothesis. What are the basic attributes of a good research questions? We'll take a few examples, and then when we are in the planning stage, we are expected to write a protocol, and then we submit the protocol to the IEC or the review board, IRB in some of the institutes they call. So, and then in this we actually have a sort of format in which we are supposed to present our research idea, which is nothing but the protocol, or sometimes people call it synopsis. So this is basically a document which is going to guide you how, or you're going to give an idea to the reviewer who's sitting at the IEC, that how are you going to conduct this study. So because there are several parts of this protocol or the document that you are going to present to the IEC. It encompasses the research question, research hypothesis, and the next thing that comes here is the aims and the objectives. So I would stop myself at the aims and objectives, considering in the want of time, and it would be subsequently dealt. This is the beginning of your research idea, your presentation of a research idea. So I wish everybody would have asked they're asking the right question. But as you grow old, you would increasingly understand asking the right question is the most important step. As you all rightly pointed out, that finding a good research question is the most difficult part, and it is actually the most difficult part, because we are always bound by the logistics, we are always bound by the feasibility issues. Therefore, finding that good research question is definitely the bottleneck. Right. So let's move ahead. Okay. So why I would ask you, why is research needed? Why all of us are why all of us are I mean expected to do research? So that's a very it is definitely a brainstorming question. I would like to ask you: should thesis be a mandatory requirement for partial fulfillment of the post graduation degree? I can debate for hours and hours on this topic, and I am of the opinion that it should never be a compulsory requirement. It should always and always be a requirement that the person takes up voluntarily, because many a times we have seen, in the name of a thesis or a piece of research that the student needs to conduct as a part of compulsory requirement, we do not produce quality. So it should always be left to the researcher or the student, whether he or she wants to take up a topic for research during the post graduation. And many a times when we have that inclination, or the, I mean, it has the other side of the argument is, you, if you want to build something, you may have to force something.
எங்க சார் லேப்டாப் கொடுத்தாருன்னா நீ யூஸ் பண்ணிக்கோ. சப்போஸ் அவர்
Okay?
கொடுத்தாருன்னு தெரியல, கொடுப்பாரு.
So the
9 o'clock வேணும்னாரு.
Please mute your audios, please.
Yeah. So I sincerely believe that research must be done with an intent of advancement of science. So if we don't have this intent, all our efforts become we understand, as a in our career we may have to produce some great studies or at least some publications to get jobs, to get promotions and things like that. But there are much more stuff beyond that, and at a philosophical level, if you don't think you're making a good making a difference to anything, you should not do that piece of work. Okay, now let's come here. So that's our research question versus research hypothesis. Okay, so are the same, or they are, or they are kind of synonymous? And I have already written the answer. So the research question and research hypothesis are many a times considered, I mean, people do not distinguish between these two entities, but there is a definite difference between the two. Okay, let's see how. So let us look at the similarities first. So they are tools that are used in a similar way when we are actually expressing what are we trying to do, or what is our intention in this piece of research. And they both have to be framed at the beginning of research. I mean, before conceiving the idea, you should first, I mean, whenever you have got an idea, you have to express them either in form of a research question or in a form of a research hypothesis. Now, when I say synonymous, so, and I am using a term or, that means they are synonymous, but they are not. You have to frame both the research question as well as the research hypothesis. Let us see how. So what is an hypothesis? So here I would just try to deviate a little bit. So there is something called deductive research. There's something called heuristic research. So heuristic research is more qualitative in nature. It tells you, it does not try to analyze anything, but the deductive research is more analytical research. So when we talk of hypothesis, it is an essential component of the deductive research. It is a question. Hypothesis is always a question. And where the researcher uses the logic to prove or disprove with an educated assumption. So educated assumption, by educated assumption, I mean, he has already read the literature. He has got a base for himself to think upon and build upon. And then to do that, he actually needs a lot of preparation. And just to framing the hypothesis actually may take months and months. And please understand that this is a very important part of your statistical plan of the study, because based on the hypothesis, we actually make the statistics around it. We do the sample size calculation on this, and we also do the conclusion of the study with this. Okay. So when we write the conclusion, we say, okay, we hypothesize this, and we did find that, or we accept our hypothesis, or we refute our hypothesis. So in contrast, the research question is a statement in form of a question which does not have an assumption in it. It is more explanatory in nature. It does not have any dimension or magnitude in it. We will see in an example how we are trying to do this. It is more qualitative in nature. But the structure of the research question is very important. We will see, everybody who has written a protocol must be aware of this PICO format or PICOT format. So the research question must incorporate the components of the PICO. That is, who are the participants, what is the intervention, what is the comparator, and what is the outcome, and at what timeline you're going to measure the outcome. Okay. So let us look at this example. So what is the difference between the HbA1c lowering efficacy of metformin and pioglitazone for a patient with type 2 diabetes mellitus? So this is my research question. But if I have to go back and move forward, rather, I would say, if I have to move forward and form a research hypothesis around it, so that I can do a sample size calculation, I can make an educated guess, as I said, that okay, metformin lowers the HbA1c to this extent, pioglitazone is not so efficacious, and I mean, it's a low efficacy drug for when it comes to HbA1c lowering. So though both of them would fall into the similar anti-diabetic drugs, so I would try to, so I will need to have this information in my head before I frame this research hypothesis. So the hypothesis for this would frame like that. When I write presume mean, I would say we generally use the term hypothesize. So we hypothesize that there would be a difference of 0.5 milligram per deciliter difference between the HbA1c lowering efficacy of metformin and pioglitazone in patients with type 2 diabetes mellitus. So this is a research question, and this is my research hypothesis. Based on this research hypothesis of 0.5 milligram per deciliter, and then, so this is the delta that I would like to detect. So I'm just giving a comparative study, taking some drugs so that the pharmacology residents would have a better understanding about the concepts. You may have several other kinds of research questions and research hypotheses too. Okay, I've taken a couple of examples in my subsequent slides too. So now your homework is to pair 5 pairs of research questions and research hypotheses that you would like to conduct in the interest areas of our research. Like I said, the interest areas of research are the broad topics where we are interested in research. Let's say for me, it is the immunosuppressant drug. I can look at the immunosuppressant drugs in renal transplantation, in liver transplantation, in let us say in SLE. I can look at the bone marrow transplantation also. So broad area of research is the area where you want to, and then gradually you have to narrow down to find a specific research question which you would like to investigate. Okay. So these are the attributes of a good research question. These are very nicely described in one of the pediatric surgery articles. So this, just remember the attributes of a good question is finer maps. This is the acronym. And let's see how it, I mean, let's scroll through it in a very swift manner, because the finer maps is very nicely described acronym, and you can just remember it for your exams or something. But the basic tenets we have already described. Okay, so this is feasible, interesting, novel, ethical, relevant, manageable, appropriate, potential value it should have, and that potential value should earn a publication, or it should be publishable, and the whole process is actually systematic. Okay, let's see how it is. So it is feasible. It should be feasible. Like we all understand that access to the people, logistic, documents, statistics, everything is incorporated in this feasibility. And this actually ensures a priori how, I mean, whether the research idea which we are thinking is going to be successful or not. So all the software, I call it the software, like you mentioned. I love to call them as softwares when you say the skills and the knowledge. So they are two different set of things, please remember, because the knowledge you can gain on the internet. There are many resources for teaching you how to conduct research. And but the skills, they are sort of have to be learned over a period of time, or you make mistakes and learn from those from those when you implement those readings into practice. And this is where the value of mentor also comes, that you may take years to acquire that skill on your, or I mean on your own. But if you have a mentor or somebody who can actually guide and actually make your learning curve very steep and make you progress faster. And then it is the hardware. I call the hardware the instruments, the let us say I need an HPLC, LCM, SMS, I need a spectrophotometer, I also need, let's say, BP measuring apparatus. These are the hardwares. So are they available with me if I'm going to conduct a simple research on a hypertension patients, and the patients are already taking drug. It is my observational survey. My hardware is only the blood pressure instruments, and I have to know how to keep it. So the SOPs of handling this hardware and then the SOPs of handling this software actually go hand in hand. Right, let's see. And it should be interesting. So is it interesting for the peers or the scientific community around you, or it is interesting to the lay public? So are you investigating an interesting idea? So let us see how it is. So it should be intellectually stimulating for your peer group. It is likely to invoke an academic and intellectual debate, let's say, because most of the research question actually start with a gray area in the understanding of a disease or a treatment in a specific area, right? So your research is, if it is likely to invoke an academic and intellectual debate, then it would be possibly interesting. And it should be therefore it has to be backed by prior scientific knowledge. As I said, finding a hypothesis may take months of reading, right? Then now let's come back to the novelty of the thing. Is it new? If it is not new, it is not going to add anything. It's not going to be interesting. Like Jamuna madam just said, that if there is you have conducted the research 3 years, 3 years is a small time, let's say 6 years back, and then during this time the evidence has evolved and nobody finds the other drug, or let us say the drug has the patent of this drug has expired and people are not interested in publishing research with this. So it always has to have this contemporariness to be able to gain visibility. So like we say, it's like wearing a dress. So people are always in favor of contemporary fashion. Why? Because we all want to gain visibility. So let us say this bell bottom stuff actually was there in the 70s, and then it got I mean nobody asked about it, but now when you wear bell bottom, it is very much in fashion. So it's like that. So your research also should be in fashion or in vogue. Okay. Then let's say, can you do that without compromising your ethics? So you have a bright research idea, but if your research is not ethical, you may not actually I mean you will be rather punished for doing that research. Something like, let's say, hypothermia experiments conducted by the Nazis. So we did not know how at that time we did not know how hypothermia actually helps, I mean how hypothermia actually injures the tissue, or hypothermia would preserve the organs. So the Nazis subjected these Jews to all the temperature lowering experiments, dipping them into cold water, keeping them in ice blocks and stuff like that. If you look at the usability of this research, it is really, really helpful in terms of, let's say, if I put my kidney before transplant into the cold ringer instrument, how helpful it is to actually reduce the reperfusion induced injury which can happen when the kidney is put in tissue in situ after transplantation. So or let's say the soldiers fighting in the sub-zero temperature at Leh, how can we prevent the organ injuries in these soldiers? So they are useful information, but however the way we elicit the information should be ethical. Okay, next. So it should be relevant also. Why relevant? It should fill the knowledge gap. It should, as I said, it should be analyzing some of the professional or academic assumption, or it should be monitoring the development of a practice, or it should be comparing different approaches, different treatments. Okay, next. And then it should be manageable. Manageable, as we said, it is kind of manageable is kind of synonymous with the feasible. So you should be able to manage to complete the research project which you thought you can do. So many of the things, because of the manageability issue, may die out in the middle. Then it should be appropriate. So this appropriateness is again at the ethical and kind of, it's also synonymous with that. Then it should have a potential value for publishability. So why should people be interested in reading your research findings? It should be as I said, it should have some contemporariness, or it should have some novelty which would attract the scientific community, even the lay public, whether it would be helpful or not. Something like a corona research, which the lay public is also interested. Okay. Now the next thing is it's systematic. So the whole process is actually systematic. The developing this ability to synthesize and express complex ideas, demonstrate information literacy, and to be able to work with evidence. These are the steps of this systematicness. And as I always say, it is a work in progress. For even for a seasoned researcher, it is a work in progress. Okay, so let's see the types of research question. There could be several types of research question, existence type of question. So it investigates presence or absence of a problem. So can neonates perceive pain? I actually wanted to change this. So do neonates have a different blood pressure range than the adults? This is one investigation which just you want to find the existence of an entity or not. Then the description and classification types. Let us say what are the characteristics of and types of hypertension in the adults. Here you will investigate essential hypertension, secondary hypertension, etc., etc. Then the composition type of research question. So what are the stages of hypertensive heart disease? How does it evolve? Stage 1, stage 2, stage 3. We already have, people have described this. Okay. So this is the composition kind of research question. Next is the relationship. So what is the relationship between blood pressure and the hypertensive vascular complication? Okay. So we may have to look at the differences in terms of the degree of blood pressure elevation and the vascular complication like cerebrovascular accidents or the hypertensive heart disease. I've taken the example of blood pressure actually. So descriptive and comparative. Do children with secondary hypertension develop similar complication compared to the adults with secondary hypertension? This is a very specific question. Okay. And it tells you what to investigate, who is your population, and how are you going to investigate? I mean, what is your endpoint? That is your complications. So the causality type of question. Does familiar hypertensive disease lead to worse outcome in patients who have onset of this hypertension before puberty? Okay. Now the causality can also be a comparative thing. So is the survival outcome is different between the familiar hypertension or the secondary hypertension? Something like that. So irrespective of your type of question, I mean, you may fall under any of these, but it generally does not change the type of question, does not change the relevance of your research or the validity of your research. Okay, so these are some quick things. Begin with a broader area of interest. How do you frame? As I said, it's a broader area of interest. You do a preliminary literature search to find the information gaps and find what is still not known, and it could be an implied question also, and then you come back and narrow your focus and frame a research question. After even framing a research question, revisit it, always go back and see whether the relevance is there, whether these gaps have been filled. I mean, always ask and re-ask yourself, ask your peers, ask your mentors whether this is going to be a meaningful research. Okay, till you are actually satisfied and starting to write your protocol. Okay, so when you start to write down, you write in your own words. It could be as lengthy and as complete as possible. Specify the population, exposure, comparator, and outcome. As I said, these are the PICO components. And then also see till what time you're going to do that. And then after all this is done, this is your research question component. Then you start developing the research hypothesis. Okay. Now there are two things. What are the research, like you already have now the research aims and the research hypothesis. Now, beyond that, you will just, so this will allow you to write your introduction part of the protocol, where you would say how this research question arise in your mind. And here he would actually describe what is already known on the subject. Many of the publication, when many of the journals actually require the statement from the researcher, what is known on this subject, and the second segment is what this study adds. So these are actually the components which you should think even before you send for a publication. So that actually tells you the potential for publishability of a research. So all of us actually conduct research not to just submit a thesis, but also to that. Therefore I say, when I am conducting a research, I'm having that intent that it should gain visibility, it should add to the scientific literature. Therefore, a priori, I should think what is already known about the subject, what this study will add. May it be a very small gap, but or may it be trying to address some of the questions which have not been answered, or there is a controversy between the researchers or something like that, or there is no data on your population, and you sincerely believe that this population is going to behave differently than the other published literature population, like that. Okay, so after your introduction, when you write your research question, or you explain how the origin of the research question, then you come to the aims and objectives. So again, are these synonymous or complementary? Because many a times the students will write aims and objectives, and then these things will flow. So it is actually not synonymous, and they are rather complementary, because the aim describes, it is the what of the research. What are you going to do it? Are you going to do is nothing but the objective. Okay, let's see how. Okay, so research aim actually states the big picture. Research aim is nothing but you explain the research question. So what you expect to do in this is what is your research aim. And they say it is an infinitive verb, because it says to plus an action word. So something like to investigate the effect of blah blah blah, to understand the natural this thing, or to understand if there is a difference between the efficacy or safety of the drug, or to understand the effect of add-on therapy of XYZ on the standard care regimen, or to compare two drugs, or two intervention methods, something like that. Okay, so it is always an infinitive verb, to plus an action word. This what I am stating is the convention. You may choose to use different words. You may choose to express your research aim in a manner which says that it states you the bigger frame. Okay, that you expect to do that with this research, you will do this. Now let's come to the next thing, which is the research objective, which is usually more than one. And it describes the specific steps you will take to achieve your aim. It should be practicable, it should be doable, it should be achievable. So all your steps actually should be complying to this statement of practicality. So often presented in a formatted list or a bulleted points, it's relatively precise. It includes the tool and the outcomes of measurement, and also in the order of their importance. And the important point is, whenever we submit a research grant, we say these objectives are going to be met in this timeline. So usually we think that if the researcher has clearly framed his timelines or for the objectives, he has more clear vision what he wants to do. So typically they are called Gantt charts when you submit the research proposals, and it actually gives a state of clarity of mind of the researcher. So your objectives actually should be very clear and aligned to the research aims. Okay, so let's see. I have just taken one example from my publication, that is a present study. A present study aims to compare the efficacy and safety of tamsulosin and tadalafil on lower urinary tract symptoms and erectile dysfunction in patients with benign prostatic hyperplasia in a crossover design. So here I could have stopped here also. The inner crossover design is kind of adding to the, again, as I say, your research should sell. I mean, people, what I mean to mean by saying sell here is your research should be able to gain visibility. That's the purpose we are trying to get the attention of the scientific community to what we have done. So doing a crossover design is something which people had not done so far. So that is where I just added, you have to be, that comes with a little bit of experience with that we learn over a period of time. So adding this design possibly would gain me more visibility that, okay, these people have not done a parallel study, but they have done a crossover when tamsulosin and tadalafil were actually crossed over to see whether people who did not respond to tamsulosin responded to tadalafil. Something like that. Okay. And we had an interesting finding in this study. Okay, so next is my this is my last but one slide, Dr. Melvin. So primary objective, secondary objective, and exploratory objective. So my research objectives can be divided into primary, secondary, or exploratory. Sometimes people use synonymously the term endpoint, and which is nevertheless the kind of convention. You can separate out those two things also, because whenever we write the aims and objectives or the plan, we write objective, and whenever we are describing the statistical part or the sample size part, then we take the end point into account, so that we do we justify what we had done. Okay, so first thing is to compare the magnitude of effect of tamsulosin and tadalafil in relieving the BPH LUTS using International Prostate Symptom Score. So you see, you have also mentioned the instrument that you are going to use. By instrument, I mean this scale. You have also explained the drug which are the comparators, and you have already explained what you are going to measure. Okay. The secondary objective. So this is the first and foremost thing that I'm interested in. Okay. Whether LUTS gets relieved in the BPH patients using the these two drugs when I am measuring with the IPSS scale. Now, the secondary objective is comparison of improvements in the erectile function. So my object, because I already know that tadalafil causes improvement in the erectile function. So that's not my primary objective. Nevertheless, using this objective, using this parameter as a secondary objective actually validates the already existing information about this drug. Okay. And tamsulosin, we know some patients it caused retrograde ejaculation. So this is just part of the primary, the secondary objective. Then we are also going to see the adverse effect. And then I have stated something like exploratory objective or exploratory endpoint. So we say assessment of residual effects on the BPH-LVH symptoms. So we wanted to know whether if I am stopping these drugs have any disease modifying effect, or they are just, and does their effect last beyond 2 weeks of administration. Okay. So now I always tell my students that before knowing what to do, you should know what not to do. So too many aims actually leads to too many objectives, and it's always good to have research studies with single most important question. And there is no harm in having multiple secondary objectives. Okay. And the exploratory objectives always give you a basis for generation of hypothesis for your future studies. Right? Okay. So with that, I'll end, and I'll be happy to take any questions if you have. And this I would like to quote. So the blue part is my addition, because many times an idea or innovation, though is very much in vogue, we may not do a very great innovation in our current settings, but we may try to solve a problem that we see in a day-to-day practice. Or by day-to-day practice, I would also mean the clinical practice. That so developing this creative thinking skills is very important, and that's how we will be able to frame a good research question. And nevertheless, that requires a good base of your understanding of the area or the basic research areas which you would try to pursue in future. And the idea is to kind of grow vertically. And initially you may you may take time to understand what your interest areas are, and but when you are convinced, you should be more vertical in your growth rather than horizontal. Thank you very much.
Thank you, Dr. Smita. So I'm sure that was a very lucid presentation for all of us to understand about research question, framing a research question. So there are a few questions in the chat box. I'll read it for you. You could probably answer them now. First one, is it always mandatory to have a research hypothesis? Isn't a research question alone sufficient?
Right. So I would say a research hypothesis actually is where, I mean, many a times your statistical considerations are based on the research hypothesis. So a research question, as I said, is many a times more descriptive in nature. It is not uh, analytical in nature, in the sense that I would like to see the incidence of let's say Alzheimer's disease in so and so community. Okay, so it is descriptive. It cannot have a hypothesis in it. If I say, I presume that the prevalence of Alzheimer's is going to be 30. I mean, let's say 5% in this population of 10,000. It is a hypothesis. Now I have to either accept this hypothesis or refute this hypothesis. So you are correct. Many a times, the descriptive studies may not necessarily have a hypothesis in it.
Okay. The next question is it mandatory to mention secondary objectives in thesis?
No, not at all. These secondary objectives are for the researcher himself, or the less important. I mean, secondary framing the objectives into primary objectives and secondary secondary objectives actually improves your systematic approach, I would say, because there's always something you would also like to see apart from your primary objective. Nothing is mandatory. If you can justify that why you did not do it, post hoc. So let's say the peer reviewer asks you, why did not you see that? You see the outcome hypertension, but you did not see the outcome which is like sleeplessness or the adverse events. So it may come up in the peer review process, and once you have done something, you cannot go back on it. So maximum thought and maximum as I say, the creative thinking and the critical thinking should always be exercised at the beginning. So organizing them into primary and secondary outcome is a good way of presentation. It is not mandatory, I would say.
Okay, thank you, ma'am. The next question, the last question, probably after this, we'll have questions during the Q&A. Is it right to publish secondary objectives as a separate paper?
No. No. It is actually called salami publications, or it is actually considered unethical. When you have framed a research, increasingly these things are coming into the publication ethics purview. When you have drafted a protocol, you have your primary objective and you have a secondary objective, and your study is powered to answer only this primary objective. The secondary objectives are, again, they could be an indicator for hypothesis generation and can be tested in a separate study. Even if you find significance in the secondary objective, you should report it in the same piece of publication where you are reporting your primary objective.
Yeah. Maybe we'll have one last question again. Why descriptive studies do not require hypothesis?
Why descriptive studies do not require hypothesis is not always true, because as I said, it is, if I say that, okay, I presume that, okay, 5% of the population may be having Alzheimer's, that is how I calculate the sample size, even in a descriptive study. Or let's say I am seeing in one part of Chennai it is 5%, somebody has already reported, and I have to now conduct a study in different part of Chennai, and I am hypothesizing that, okay, in this population, okay, let's say there is some water contamination in that area with some chemical, and I presume that worsens the Alzheimer's thing. So there I would presume that, okay, this area had 5%, and considering the baseline as 5%, I presume that it is going to be 6% or 8%. So it is again a descriptive study only, but you are adding an analysis point, a component, saying adding a hypothesis here. So I would not say that, but what you are doing is a prevalence study only. But at the end, when you have a hypothesis, you are actually comparing two data sets, and both of them are descriptive studies only. So it is how you want to answer the question that you have framed.
Okay, thank you, Dr. Smita. So with this, we'll close this session. Once again, I wish to thank you for giving your time for NCRM 2020.
Thank you, everyone. Thank you, Dr. Melvin, and thank you, ma'am, for having me here.
Yes. So now we'll have a break, and we'll be back for the next session after 10 minutes. We'll start the next session at 11:10, and we'll start with literature review, and after that there is one more session on observational studies, followed by a Q&A session. So if you have any questions, please feel free to type it in this chat box. It will be taken up during the Q&A session. So thank you.
Professor Rani, and then my regards and gratitude to the entire organizing team at SRM for inviting me to this wonderful national workshop on the clinical research methods. And once again, I would say that this is a great initiative by Professor Melvin, and I will be going through very quickly on a topic which is, I think, the fundamentals of literature review. So let me share my slides, and if there are any questions, I'll be happy to take. I've been, advised by Dr. Melvin George that I should give you some homework at the end of the session. So I have my last slide is on that homework, and let me pull my slides. So, are my slides visible?
Yes, it's visible. You could just put it in full screen.
Yeah.
Yes.
Okay. So again, thank you very much for this invitation. It's an honor to be here, and my great friend Melvin, he is doing a wonderful job of organizing these capacity building workshops for clinical research. And I think this particular session is extremely important to embark on the journey of clinical research, whether you are, and I've been told that, this is a completely multifunctional group where we have, people, doctors from different specialities. These postgraduate doctors, as well as we have faculty members from the different specialities. So I'm going to make this as generic as possible. And so just remember that when we want to kind of do any research study, the most important thing which our guide tells us, this is primarily for the PG students, but also for any other researcher, is to do a medical literature search. This is the pillar of an effective research. This is the pillar or the foundation on whether your research is going to be proper, or whether your manuscript which will be developed is going to be accepted or not. So let us see. Today's agenda will be to help you develop a research question, understand the basic database of medical literature. I will also take you through the Boolean logic. I will also help you through some tricks and tips of how you can do literature search in a very fast and efficient manner by using field searching. Also, the use of controlled vocabulary. I'm going to also share the experience of how you can do specialty searchings like truncation, and how can you build your search strategy. So this is the agenda for the today. So what is the benefit of good literature search? The most important benefit is that it prevents you from duplicating the work that has already been done. So as I was mentioning, that if you're a postgraduate trainee and you are a postgraduate trainee in gynecology and obs, and you want to kind of do a particular study in comparing the injection betamethasone and the lung function maturity in third trimester of pregnancy, and you want to compare it with a new steroid, you must see whether this study has been done previously or not. It could be done elsewhere in the world. It could be done elsewhere in the country. You never know, it could have been done in your own department. So if it is done already in your department, this is a duplicate work, or this is a high chance that your thesis might not get accepted, or your manuscript might not get accepted. So a good literature search will prevent you from duplicating the work. It helps you by synthesizing information from previous studies, and you will be able to get a stronger background and justification and discussion of your own study. That why did you do this study? Suppose I'll give the example of one of my studies, which we currently did, is that there were a lot of knowledge, attitude, practice studies about COVID-19 in the general population from different parts of the country. When we looked at the literature, we saw that KAP studies were done from Jammu and Kashmir, They were done from Maharashtra, they were done from Kerala. But in our own state of West Bengal, there were no studies done. So it gives us the impetus that yes, we must do this particular study in our state, and this will be a new addition to the medical literature. So it will give us to have a stronger background. It will give us the justification to do this study. And finally, it helps us to build a strong discussion. And I'm happy to tell you that this particular paper got accepted in a PubMed Index journal very, very recently. A couple of weeks back, this paper has got accepted. It's the first study from West Bengal. So relevant studies can provide you insights and tips to make your own study better and best methodology or data analysis method. So we looked at one of the similar studies from Maharashtra, one of the similar studies from Jammu and Kashmir. They use the Google Forms. We use the Google Forms. They use the social media platforms. We have used the social media platforms. They used the pre-validated questionnaire. We use their questionnaire. So this helps us, this previous medical literature which we got on this KAP study in COVID-19 among the general population, this literature search helped us to design our study, to analyze our study in a much, much better way. We were also able to, you will be also able to identify gaps and weakness in the extensive research, in the existing research, and come up with a useful and meaningful research question. Again, going back to my KAP study in COVID-19, we looked at the gaps. So some of the gaps were limited number of samples. So in the Jammu Kashmir study, there were 250 participants. In the Maharashtra study, there were 300 participants. We aspired to get more participants. So that is the weakness of the study, that it has got less number of study participants. And it also helps you to give a meaningful research question. But we were also looking at what is the data from Eastern, Northeastern India. This is very, very important that your own study can add a lot of value in your part of the country, in your part of the world. So never think that a study which you are doing is of less value. It might be the first study in your region. It might be the first study in your state. It might be the first study in that country. So how will you know it? With the help of good literature search. Finally, it will help you to make familiar with the terminologies by using and finding key suitable keywords. So why do we do medical literature search? Many of the medical literature search major function is in clinical practice. So the clinical friends who are here from the clinical branches, let me tell you, you will have to undertake literature search when you pass, even if you are passing out, if you are practicing, because every day, a new thing is getting added to the medical literature. There is, for example, again, coming back to COVID-19, hydroxychloroquine, whether you will use it, you will not use it. Is there a systematic review? How would you find it out? Whether ivermectin dose should be used 12 milligram, ivermectin dose should be used 18 milligram or 24 milligram. What does the literature say? Does the pharmacokinetics change in critical care patients of these important drugs which are being used in COVID-19? So for clinical practice, the most important is to do medical literature search. This is usually the doctors, all the practicing doctors, they are undertaking it. Now, you also, in medical education, medical literature search has got a very important topic, a very important role. The teachers, people like Dr. George, they will do a particular recent update on what has come in this particular topic, because books, ladies and gentlemen, are usually at least on an average 1 to 2 years backdated. They are backdated because that is the time taken by the publishing houses. So whatever book you see, whatever book you read, it's not the most updated thing. You have to go into the databases, the medical literature databases, and search it. You also have to find out the best standard treatment guideline, and the standard treatment guideline will come through the medical literature search. And the most important thing is to practice evidence-based medicine, medico-legally, very, very important for all the people who are into practice, because you have to find out what is the best available evidence. I'll give you an example again from COVID-19, ivermectin and doxycycline. 1 month back, ivermectin and doxycycline was not included in the guidelines of the West Bengal government, the health department. But when there was adequate literature available that yes, this drug combination therapy helps in COVID-19 patients, they included it. So this is very, very important that medical literature search is going to help you not only to design a good study, but also in proper patient management. There is information overload, and we know it better than anybody else. If you open WhatsApp, you will find so much information overload going on right now. If you look at the databases and primarily PubMed, you know, there are millions and millions of articles, thousands and thousands of articles which are getting added. So in 2019, there are close to 9 lakh articles, and this is data close around, we have not included 2020 data now. So maybe this number has gone past a million. So the Medline contains over 18 million journals. So much of information is present. So how will you find your information? That is the question. If you are a PG thesis student, if you are a researcher who wants to publish an article to get a promotion, how would you find? Always design a research question. The research question will form the base of the search. Patient in the research question will have 4 parameters. PICO, patient, P stands for patient or population or problem. I stands for intervention, C stands for comparison, and O stands for outcome. Always break down. Suppose your thesis guides wants you to do a particular topic. You break it down into these 4 components. Giving an example, suppose you are an orthopedician, you are a MS orthopedic student, and your thesis guides want to look at the functional outcome of humerus fracture with the help of a particular surgical intervention. So what is the patient population? It is the patients who have undergone, who have suffered humerus fracture. What is the intervention? How do you want to intervene? So you want to intervene either through a conventional method or through a new method. You know, that is what the new method comes under the comparison arm. And outcome, what are you looking at? These can be morbidities, these can be death, these can be complications. So every time you want to embark on the journey of medical literature search, divide it into a PICO question, divide it into the patient aspect. What is the intervention or exposure you want to intervene? What is the comparative arm you want to see? And what is the outcome you want to look at? So you parse the question. This is very, very important. You have to parse the question, the main concepts in your question. I'll give you an example. Suppose somebody wants to do a study on nutritional therapy. Does nutritional therapy improves decubitus ulcer in ulcer healing in an elderly patient? What are the different questions, which concepts which come into mind? The most important thing is nutrition therapy, and it's the patient population will be what is the clinical indication you are looking at, decubitus or pressure ulcer. You are trying to look at the ulcer healing outcome. There is another concept that you want to look in specifically elderly patient. You are not trying to look in the pregnant patients, or you are not trying to look in the healthy adults. And you want to look at the treatment and efficacy. So you write down whenever you have a medical literature search, first frame your PICO question, and with the help of the PICO question, you write down the different concepts, the key medical concepts or the key medical keywords which are important. So this is very, very key. This is important about the thing. Hello? दुबे जी मेरा मीटिंग है मैं একটু পরে আপনাকে ফোন করছি sorry. So the very, very key concept is first you write it down. You write down these key concepts from your questions. Now you look in the database. The question is, which database do you look in? For the paucity of time, I am going to limit my discussion to PubMed. And I'm going to tell you about the tricks, how you can utilize the PubMed in a very, very efficient manner. What are databases? They are electronic collections of medical literature. The bibliographic databases are searched. And there are many databases, you know, you can look at EM base, you can look at, there are many, many databases, but for the focus is going to be on the PubMed, but these techniques can be applied to any literature database. So the searching a database should provide the ability to search a specific item. You should have the ability to search the related item. You should have the ability to search specific fields, and very, very important, combine Boolean logic. I'm going to come to that very, very soon. An ability to retrieve the search results. Now, this last point, ladies and gentlemen, is very, very important. We do a lot of search on PubMed. We do a lot of search on PubMed, but how do I retrieve this? How do I put it into my, I put this under my control? This important step is also very, very essential, because you might do a hell lot of study research, but you are not able to retrieve it. So this is going to be a tricky situation, and I'm going to tell you in my last slide how you can retrieve these search results in a very, very efficient manner. What is Boolean logic? It is named after the British mathematician George Boole, who developed the algebraic system in the United Kingdom. The Boolean logic is very, very complex. I'm not here to teach you algebra. So it's very complex, but this is the logic. On the basis of this Boolean logic, the majority of the databases could be searched. There are 3 Boolean operators, and these 3 Boolean operators can help you search any database in the world. These 3 operators are AND, the simple and you don't write it with a small letter, you write it with a capital letter, capital AND, and, or, not. These 3, trust me, are very, very simple, yet very powerful operators to search anything you want, depending on your research question. What does the word AND do? It includes both the terms in the results. So if you give an example that I want to search from travoprost for the ophthalmology people and glaucoma, and you put AND, so it is going to include in the result where the title had both the names. So this is going to pull that particular article where travoprost and glaucoma was present. Or it is going to search either or. So either it will search so it is going to search in the title, either travoprost was present or glaucoma was present. Very, very difficult sometimes very, very difficult that either or the or, but it is very important to use the word or, especially when you are doing a rare drug research or a rare therapy research, because it is not going to include both the terms, it is going to include one of the terms. Okay. And lastly is not. It excludes any result which does not include the term. So if you want to search, suppose you are doing a drug utilization study for the pharmacology students, I'm telling this, for the MD pharmacology students, if you want to do any particular study on, a drug utilization study in your hospital on what are the drugs which are being used in the medicine OPD, which are not antibiotics. So you search the literature database by using not. Records containing both will not be retrieved. So it is only going to retrieve the drugs which are not antibiotic. So always remember 3 important Boolean operators. The most important of them is and, or, and not. So how do we use the word or more efficiently? Or groupings contains the same idea or the terms, and they usually put in parentheses. So say for example, there could be a particular medical condition, a particular medical terminology where you can have synonyms. So you can put the synonyms together. I'm giving you just an example. It could be faculty or teachers or professors. And you put the synonyms together with or, and you put a first bracket. So it is going to search any of these terms in the title of the article. And this is very, very important because many a terms, we might be utilizing a particular thing, like we use management of COVID-19 patients. We can also use pharmacotherapy of COVID-19 patients. We can also use medicines used in COVID-19 patients. We can also use drugs used in COVID-19 patients. So all these 4 words, they can come as or, and they will be included with the first bracket. So the the operator is going to search either of these terms in the title of your article. And what the AND will do, we have already mentioned that AND groupings contain terms of different ideas and they can be combined with or. So heart attack and smoking. So any article which will have heart attack and smoking, this will be pulled out. Diabetes and exercise, this will be pulled out. So if you want to look at an article where what was the cancer, any cancer, it could be an oral cancer, it could be a stomach cancer, and you put the word and within the parenthesis, that is within the first bracket, you put therapy or treatment. So it is going to pull the article where cancer in the title, cancer was present with treatment, cancer was present with therapy. This is extremely beneficial because many a times we kind of trying to do these searches, we will not include the word therapy and we will only use the word treatment, and we will develop a very good paper. And the reviewers, because I am reviewer for many journals, primarily international journals, we do this search and we find out that the article has not included one or two very key component article, and as a result of which we always say that this is an incomplete submission, this discussion is not complete, either a major revision is required or we directly reject the paper, because if your discussion is not complete, your inference is not proper, and as a result of which the paper can get rejected. And of course, I have mentioned about I'm not going to go into details, students who are not dental, diabetes, which is not juvenile. So now you put them together and so if you have to, like by using a Boolean logic, if we see this example, is travoprost eye drop useful in treating glaucoma disease? First, identify the concepts. This was our PICO question. Is travoprost eye drop useful in treating the glaucoma disease? So glaucoma disease, some people will write glaucoma, some people can publish systematic reviews, some people with the help of eye disease. Some people will put travoprost and we want to look at eye drops. The other concept could be treatment, therapy, management, as I mentioned. These are all synonyms. With the outcome can be expressed as recovery or success. And the effect on the effector organ can be mentioned as eye, optic nerve, cornea. So how do? You make your OR statements, one per concept, glaucoma or eye disease, and so on and so forth, as I mentioned. And then you combine the and in between. So glaucoma or eye disease and travoprost or eye drop and treatment or therapy or management and outcome or recovery or success. So see how extensive this search is going to be. And this extensive search is going to ensure that you get the best possible literature search. And not is not very commonly used, and if you want to use, you can use. I usually don't use it when I'm in really hurry, so I will use and I will use or, and there are a few other tricks which I'm going to tell you in another few slides, which I usually do and find out the article of interest. So beyond basic, so this is the core concept, the Boolean logic, Boolean operator concept, and, or, and not. But beyond that, field searching can be done, subject and keyword searching could be done, and there's a specialized feature of truncation. So field searching, all the databases, including the PubMed, will provide you with some ability to search specific field. It allows faster searching. So I'll tell you, when we get articles for review, and most of the articles nowadays are systematic reviews. So I will purposefully put what articles have been published as systematic review in the last 1 year or 2 years. So I will only search in systematic review. I don't need to search research articles. I don't need to search the case report, case series, because my time is limited, including your time is limited. So we have to focus our search for faster searching, and all the postgraduate trainees, whether they are from clinical or they are from paraclinical branches, their time is limited as well. So you have to do accurate searching, and the most important thing is with the help of field searching. So how can you do field searching? You want to, you follow a particular researcher who publishes a lot. Say for example, Dr. Melvin George, he publishes a lot on cardiovascular toxicities and cardiovascular efficacies and cardiovascular outcomes of new drugs. So you want to understand that what Dr. Melvin did in the last 1 year on cardiovascular. So you put this particular field as an author. Author is this field tag is put with the help of the third bracket, and you put AU, the short form AU, and you put this for the author field. And you want to see in 2020 what did he publish. So these are the PubMed field tags. Whenever you are searching, you should put author as AU, TI for title, TW for text word, DP for date of publication. I commonly used only two of them, to be frank with you. I use the author and the date of publication because it helps me to target any particular author who has published a lot. And this you can understand if you have done a extensive research first, and then you understand that there are certain people who are publishing a lot on a particular topic. You will be able to target these searches with the help of these field tags. And this is a simple example. This is the PubMed website mentioned, which is by the National Library of Medicine. I would like to make a point here. Everybody, please have your account. You please have your account at PubMed. Get your username, password. So I searched for myself. That's the only thing I could do well. So I searched for myself, and I wanted to see what all has come up in 2020 at the date of publication. So I put my name, and then I put author, and then I put an I'm sorry. So I wanted to see what I published in 2020 as the date of publication, and I found out few of the articles which have been listed on the PubMed. So these could be compared with the different Boolean queries. So I could have jolly well put this and hydroxychloroquine. We had just published this particular systematic review on hydroxychloroquine used in COVID-19. So there are apart from PubMed, I would also request the audience to look at the ISI Web of Science Citation Expanded Index. This is an important particular database where many of the Indian journals are listed. It is also managed by the Walter Kluwers. So you can find, not many of them are on the PubMed, and it doesn't mean that if the article is not on PubMed, that article is not worthwhile. This is actually not the this is actually not the right frame of mind to say that any article which is on PubMed is actually an acceptable, is actually acceptable, and the other ones are not acceptable. So how do you combine? You can combine, and this is an example that, we want to find the field searches. So in 2014, what Albert Alm as an author published in Latinopros, you're particularly looking for a particular title of the article of a particular author. So if you are very specific, you can find that thing out. A few words on medical subject headings, and this is very, very important because the medical subject headings helps you to search, and the medical subject headings take their birth from keywords. So anybody who's publishing, you see, if you send your article to a good journal, they will say, please give your keywords, the 4 to 5 keywords, because this 4 to 5 keywords are constantly monitored by the PubMed database and the NLM, the National Library of Medicine, and they convert it over a period of time to the medical subject heading. So it helps in the keywords, helps in generation of medical subject headings. Last few slides on truncation. So this is a trick to do a quick search. So you want to search for therapy, therapies, therapeutics, so many synonyms. Either you can use them with the Boolean operator, or you can just truncate it with the help of a star sign, THERAP, where the plural comes in, you just put a star sign. So either you can put a star sign or a dollar sign. I usually put a star sign. PubMed takes a star sign, and then it gives, it gives you that, it gives the related word which begins with THERAP. So it can be therapy, therapies, therapeutics. But too much of truncation is not good. So if I'll show an example, PORC star. So PORC star can be procaine, it could be proceedings, it could be process. So have a meaningful truncation. Don't truncate too much. And finally, I would say limit options. So limit options are present in the databases where you can limit. So when you are searching, say you have searched for hypoplastic left heart syndrome and diagnosis, you will see the limit options appearing on the left side. You can just limit, you can select the, many of the articles are not free text available. So, and very difficult for postgraduate trainees to write their discussion portions, something. So many a times we want to just look at the free full text. We want to look at what has been published in the last 5 years. We want to look at humans. We want to look at clinical trials, and we want to limit our option. So PubMed limit options. The other important thing is whenever you are doing your search, the very, very important thing is save your searches. This is an extremely important thing because you might do a lot of search and then you might do a copy paste on the Word document. That's tiresome. That takes in a lot of time. PubMed, if you have your username, password, can help you to save your searches. So this is the option of saving. You save your searches, and what do you do after that? You can also email it to yourself. So say, for example, I put my email ID here. I want all the results on this page to email it to me, and I want this in a summary format. Every time you search, you email it to yourself, or you email it to yourself and your thesis guide to also make him know that you are working. So that is extremely very, very important. So send an email. And when you send an email, it lands on your email inbox, and it lies in your email inbox. See what a wonderful heading it has. It has the heading of what you search. It tells you what you search and what has come to your inbox. So next time you are in a hurry, you can directly search on your inbox and get that particular thing. And this comes with the help of the PubMed results in the form of a summary format with the link below. So last few slides on another very important tool, which is Google Scholar. So don't search on Google, search on Google Scholar. Form, you again have a Gmail account, have a Google account, from the Google Scholar. One of the important things about Google Scholar, which is a bit differentiating from the PubMed, is that Google monitors the kind of activities which you are doing. So it next time you probably have searched for, say, for example, in an orthopedic surgery, you've searched for functional outcome of the humerus fracture. The Google will, next time you go on search and there has been a paper which is listed on Google Scholar on the functional outcome of humerus fracture, it is definitely going to show you the recommended articles. So you are going to be directed to that particular article which is linked to your previous search. This is important, especially for postgraduate trainees, I will tell you, because this will help you to get updated on what is being published on a regular basis. You can also set up an alert, and you can, and an alert can also be set up in the PubMed. So set up an alert in the PubMed. You can set up an alert here, and this Google Scholar, when you search it, it also has the limit. It has the field limiting. You can search with the, you can customize your search. So to conclude this particular topic, I would say always when you are embarking on the journey of medical literature search, frame your question in the PICO format. This is extremely important. And for every particular format, every particular segment of the PICO, identify concepts. And these concepts preferably should have some keywords. Write them down and club them together, have those concepts. For each concepts, determine keywords and subject medical terms. Specified field tags after terms if necessary. If you want to specify field tags is good. If you don't want to, you can do an exhaustive search. You can definitely do an exhaustive search after that. Combine terms with the help of the Boolean operator, the most powerful Boolean operator, and or. Synonyms can be combined with the help of or, and then you do the searching. Combined or statements with and. So synonyms will be combined with the help of and keep the track of your searches. Again, I would tell you, it is very, very important that you keep the track of your searches, how many articles were found, how many were selected as relevant, because this also shows a lot of hard work and the goodwill in front of your thesis guide. because this is the thing which you need to do on a regular basis till your thesis has been accepted for publication. So thank you very much again for this opportunity. These are my contact details. In case anybody wants to get in touch with me, I'll be more than happy. Thank you, Melvin, and the organizing committee for this wonderful opportunity. And I have, I have decided that we would request the participants to conduct medical literature search for the last 5 years on these three topics. The first topic is a prospective comparative study between chemical sphincterotomy and surgical sphincterotomy for acute anal fissure. The second one will be a prospective study of functional outcome of diaphyseal fractures of humerus in adults treated with closed interlocking nails. And the last one is on hydroxychloroquine in COVID-19 treatment in adults. The limit is in the last 5 years. I would request the participants, whatever they understood, they should do the literature search, they should conduct the literature search, save the literature search, and send a particular report to the organizing team so they could be evaluated and eventually they could be marked on that. Thank you very much.
Thank you, Dr. Subro, for the excellent review on literature review. And now we'll take a few questions from the audience. For this question, is it just PICO or other PICOs to choose? How to search literature of other languages? You want to?
Yeah, that's a good question. See, basically, our search, this will be limited to P codes. I would say P codes, O or T would be treatment outcomes that could be combined as the outcome variable itself. So if you have PICO or PICOTS is more or less the same thing. It is not a major differentiating factor. The other question which you have asked is how to search literature of other languages. You have an option in PubMed where you can select the other languages, but majority of the PubMed has the literature review from English. You are correct that the literature review can happen in other languages, but if it's in German or Spanish, then the abstract is only available in English. So you can include it, but I will have my reservations on doing that because I will, without reading the entire article, that is sometimes very difficult. So you can include that in your search, and in the search, when you look at this particular link, when the PubMed shows you the link is going to tell you that the article is in a particular language, but PubMed makes this necessity that the abstract should appear in English. So you can take the relevant information if you think that is relevant in your literature search review from that abstract. But if you think that is not adequate, then I would say I would rather not take that particular literature in the analysis.
Yeah, thank you. So there's another question. Can PICO be used in animal studies?
Yeah, so the question here is that it will not be patients in that case. It would be the animals. The interventions are going to be, in the animal studies, if you are doing a comparative study between, the OB rats, and you are trying to find out a particular intervention and no intervention on the other side. So the only thing what changes is that it happens in the animal population. It doesn't happen in the patient population. So definitely the articles, the articles which are published in the animal studies, if they are indexed on PubMed, Medline index journals in Google Scholar, of course, many of the articles are there on the Google Scholar. They definitely, this particular PICO format can be used in the animal studies as well.
Thank you. If there are no other questions, we'll be closing this session. You can still put your questions in the chat box so that it would be taken up in the Q&A session, the final session of the day. So thank you, Dr. Subra, once again for spending your valuable time for NCRM 2020. I'm sure everyone would have benefited a lot from the way you have extensively covered how PubMed should be used, and that will immensely contribute for their protocol writing as well. So
Thank you, Melvin. Thank you once again to the organizing committee, and wishing you, a happy Diwali ahead. And please stay safe. Take care of yourself.
yeah, happy Diwali to you too, Dr. Subra. Yeah, so now we'll go to the next session. So just give me a minute. So the next session is on understanding uh, observational studies, how observational studies are done, how they are designed, what are the different types of observational studies, and for which we have with us Dr. Palnivel from JIPMA, who's a professor in community medicine. He's done his undergraduation from MBBS from Tanjavur Medical College and his post-graduation from All India Institute of Medical Sciences, New Delhi. His primary research interests include tuberculosis, HIV, and other non-communicable diseases. And he's had more than 150 original articles published in several international peer-reviewed journals. And he's also an excellent speaker, which you will understand as you hear him speak. And we're very happy that Dr. Palnivel has agreed to be part of NCRM 2020. So over to you, Dr. Palnivel.
Thanks, Dr. Melvin, for the introduction, and I thank the organizing team for this opportunity. I think it's audible, right?
Yes, it's audible.
So I'll share the screen. I'll straight away start with the presentation.
Yes, please.
Okay, so good morning, everyone, all the postgraduates and other delegates for this workshop. So my topic is on observational studies. So I'll be taking you through the different study designs and the pros and cons of each study design, and one or two slides about what are the statistical outputs of these study designs. So before going to study designs, the most important aspect of the research is the choosing the right research question. Then if you choose the right research question, frame your objectives, do a very good literature review to understand what is already done, what is the gaps, and to understand what are the methodologies followed by the different the previous researchers. Okay. So for this topic on study designs or observation studies, so there are two terms you have to understand. So one is we call as the determinants, the other one is the outcome. Okay. So when you talk about hypothesis generation, okay, what leads to the effect? Okay. So there are two variables. One is called as outcome. The another variable is there which determines the occurrence of the outcome. It's called determinant. We call it exposure. Okay. So these are jargons. Okay. So exposure versus outcome, determinant versus outcome, a factor and outcome. In statistical language, we sometimes call it independent variable, dependent variable. The dependent is basically the outcome, cause versus effect. So these are the terms, different terms or different classification we'll use. So I will use the determinant and outcome or exposure and outcome in my lecture. Okay. So these are some of the examples. The exposure can be a drug. The outcome can be an adverse effect or cure or the mortality, alive or death, or it could be a prevention of disease. For example, vaccines. Vaccines could be the exposure or the determinant, and the outcome could be the prevention of disease. And the classical examples based on study designs usually be explained is the smoking and lung cancer. Smoking is an exposure, and lung cancer is the outcome or the effect. Okay, so excess salt intake will lead to hypertension. In this example, the salt intake is the exposure and hypertension is an outcome. But hypertension can be in another study. Okay, in a different research question or a different study, hypertension can be a exposure, and outcome could be a severe stroke or a kidney disease or something like that. Okay, amlodipine and BP control reduction or adverse effects of amlodipine. I think it will be fairly understand about what is the exposure and outcome. So it's not a fixed thing in your research question. Okay, what is the exposure and what is the outcome that you have to decide. Okay, so based on that you do review of literature. Then if you have a clear research question or objectives, then you can choose a study design. Okay, so I'm going to spend some time, 5 minutes on this, the flow chart. What are different study designs, the simplistic classification of study designs. some of the study designs may not fit into this classification, but it's good to understand how this classification works. Okay, the first thing is, let us take an example. Let me take, usually take as smoking and lung cancer. Smoking is exposure and lung cancer is the outcome. So let me try some other example here. Let us take, I think all of you are aware of isoniazid drug, which is which one of the adverse effects is peripheral neuritis. Okay. So let me take that example. So my question is, so depending on my research question, I can choose a particular study design which can answer within whatever I have the constraints. Okay, it could be the constraints could be the money, or constraints could be the time. Okay, so I want a quick study. Okay, I can choose a different study design. Okay, so let me tell you, I want to study, is there any relationship between isoniazid use and peripheral neuritis? The simplistic way of putting the research question. Okay, what I'm trying to find out, is there any relationship between the use of isoniazid drug and the peripheral neuritis? Okay, it's well known now. It's the important adverse effect of the INH when you give for the tuberculosis patients. But imagine that we don't know about this one, and we are trying to explore: is it true? Is this any relationship? Is there any relation between the isoniazid and the peripheral neuritis? Okay. The first question in study design is investigator is assigning the exposure. Whether in my study, in your study, okay, I am going to decide, okay, whether I am controlling the exposure, whether I am going to experiment, okay, I'm going to give a few patients INH, I will not give patients INH, whether you are assigning the exposure as a researcher. If it becomes, it is under your control, it becomes an experimental study. Within experimental study, if it is a random allocation, who will get drugs, who will not get drugs, that will be randomly assigned. There is something called randomization. It becomes a randomized controlled trial. I think there is a separate session on experimental study. I will not go into that. The thing is, whether the exposures, let it be smoking, let it be alcohol, let it be the drugs, whether it is decided by the investigator or it is something happening naturally and you are simply observing. You are not going to make some people smoke and some people not to smoke, and you are not following them up. Okay, naturally some people are smoking. Okay, naturally in a TV program, some people are taking INH, some people may not take INH. Okay, so you're going to simply observe what is happening. Those kind of studies are called observational studies. I think you're able to clear. This is the first point, whether the assigning the exposure, whether investigator controls the assignment of exposures, that decides whether it is an experimental study or an observational study. So let us go back to our example. Okay, it's INH and the peripheral neuritis. I'm not going to decide who will get INH, who will not get INH. I'm just going to use the data from the TV program. Okay, so I'm not going to decide which patient will get INH, which patient will not get INH. So it becomes an observational study. Then within observation study, there's two broad classifications. One is called the descriptive studies, other one is called the analytical studies. Okay, so this classification is decided by one question. In your study, how many groups you are dealing with? Okay, so whether you are going to compare with anything else or you're going to just describe what is happening in a particular group. Coming back to our example, this can be, I want to look at a group of patients who are taking INH. For example, TB patients started under anti-tuberculosis treatment. If there is no comparison group, I'm just trying to describe out of 100 patients started on ATT, which includes INH regimen. Out of 100 people, 20 people had peripheral neuritis. This is simply describing what is happening in this particular group. This becomes a descriptive study. There is no comparison. Okay, if there is a comparison group, no. People compared with those who are having INH, compared with those people who are not on an INH regimen. Among those people, what is the incidence of peripheral neuritis? If we have a comparison group, then becomes an analytical study. The basic difference with descriptive analytical study is the comparison group. We need comparison group to prove that there is a relationship between the suspected exposure and the outcome. Okay, otherwise people will come and argue, okay, I have taken ATT, 100 people took it, okay, it's peripheral, 20% have the 20% people have the peripheral neuritis. So how we are attributing this to the ATT or a particular drug in question? Okay, so we need a comparison group where there is no INH. Okay, then only you can prove that, okay, among those who are taking INH based regimen, the incidence of peripheral neuritis is more compared to those without an INH regimen. So that's why the importance of the comparison group. So these analytical studies are broadly called as comparative studies also. That means there is a comparison group. There is more than one group. It could be 2 groups or 3 groups. These studies are called analytical studies. Okay. So this is one. So first question is, this investigator is controlling the exposure. That's the first thing. If he is controlling, that means experimental study. No, he simply observe what is happening. That becomes observation study. Within observation study, the next question is whether I'm dealing with one group or I'm going to have comparisons. That becomes that differentiates the descriptive study and the analytical study. Okay, within analytical studies, there are different ways of doing comparisons. Okay, so the next question is, okay, in what direction I'm trying to explore my question? Okay, we have an exposure and we have an outcome. In our example, the exposure is the INH drug and the outcome is the peripheral neuritis. Okay, because analytical study, I need to have at least two groups. Okay, let me go with the easiest example of the cohort study. There are three, based on the direction of inquiry, there are three types of studies possible. One is the cohort study, case control. Other one is the cross-sectional studies. Okay, let me take the easiest one, the cohort, easy to understand. That's what we routinely do as a cohort. The direction of inquiry is the exposure to outcome. What does it mean? Okay, I will start with a group of people exposed. Exposed means what? A group of people who are taking INH drug. That's exposure. Being an analytical study, I need a comparison group. Who is the comparison group in a cohort study? Not exposed. Not exposed means what? They should not be taking that particular exposure. That means people should not be on INH, but maybe an other regimen or maybe on some other drug. Okay. So there is a two groups. One group is exposed, that is taking INH, other group is not taking, and you will simply naturally follow this group. Okay, for example, 3 months or 6 months, depending on the natural history of disease, how much it takes time to take to develop peripheral neuritis among patients who take INH. So these information will be given by review of literature. How long I have to follow up the patients for the outcome. So in a cohort study, you start with exposure. Those who are having INH, those who are not taking INH, follow them up till you get the outcome, whatever it is. Okay, it may be the peripheral neuritis or any other adverse effect, whatever it is. Okay, so these designs are called the cohort studies, where you start with exposure and follow up the patient. That is important. You are following up the patient for the study participants for an outcome. So this becomes a cohort study. Okay, so the same research question I can answer in a different way. Okay, this is 6 months. I don't have 6 months of time. Okay, I want to finish my dissertation in 3 months. Okay, so I cannot follow up these patients for 6 months. So cohort study, for this particular study, you have to follow for 6 months. The treatment duration is 6 months. Okay, let us assume. So for example, you're working on a cancer. Okay, so cancer happens like you have to follow for 10 years, 15 years. So you do not have time for luxury of time to follow for 10 years, 15 years. So in these situations, cohort study becomes difficult. Okay, can I answer the same research question using a different study design? What is my research question? Is there any relationship between INH intake and the peripheral neuritis? So I opted for analytical study. The first design is I'm comparing those who are taking INH compared with those who are not taking INH and follow them up. And the peripheral neuritis is more common in which group? Or is it same between the two groups? The two groups is INH and not taking INH. Okay. So instead of cohort study, the same research question I can answer with another design. The design is called the case control design. In case control design, you can look at the slide. It starts from outcome and goes back to exposure. Okay, that means what? Outcome. What is outcome in our study? Peripheral neuritis. My groups are based on the outcome. The initial one, the cohort study, the groups are based on whether they are taking INH or not taking INH. It's based on exposure. In case control study, the groups are based on your outcome. Outcome here is what? Peripheral neuritis. So I have to find a group of people with peripheral neuritis, not necessarily TB patients, any peripheral neuritis group. Okay, and a comparison group, case reference study. This other is called as case reference study or case control study. The other group should be without the disease. That means what? Other group, you have to take another group where you have to rule out peripheral neuritis. There is no peripheral neuritis in this group. So the grouping of participants is based on the outcome. One group with outcome peripheral neuritis, and another group without peripheral neuritis. What you are supposed to do in this after constituting these two groups? So you have to go back and ask, okay, did you take peripheral INH? You have to explore about the how common is the exposure in these two groups. In these two groups, you have to ask the same question. Did you take INH in last 1 year or in last 6 months? Okay, so this time reference has to look on the review of literature. Okay, so you have to ask the same question. What is the question? Did you take INH this much dosage or for this many days in the last 1 year or last 6 months or last 2 years? In the both the groups you have to ask. Okay. For example, in cases where in peripheral neuritis, 60% say, yes, we have taken INH drug. In other group, only 5 or 10% are telling. That means what? Among people with peripheral neuritis, more commonly they have taken the INH. Okay, this way of designing the study also answer the same research question. Okay, this is called case control study. The difference is the groups are based on your outcome, and your direction of inquiry is after the constituting the groups, you're going back and asking about the exposure. Okay, so this is the case control design. The third is cross-sectional design. Okay, cross-sectional studies, it's a broad word. Cross-sectional studies can be either descriptive. Okay, at a given point of time, for example, you have 75 participants. Out of 75 participants, what percentage are anemic? What is their average blood sugar? This is describing the group. Out of these all 75 participants, how many are males and how many are females? These are what? Descriptive, sexual descriptive studies. At this point of time, what is their weight? What is the heart rate? These are all cross-sectional descriptive studies. Within cross-sectional studies also we have analytical. That means what? Analytical, as I said before, analytical means there should be comparison groups. At this given point of time, is there any difference in hemoglobin level between males and female? I'm comparing, what is the outcome here? I'm comparing the hemoglobin level between male and female. Okay, so this becomes a cross-sectional. The cross-sectional is, here I'm trying to see gender as an exposure variable. Is there any relationship between gender or being male or female with the hemoglobin level? That means what? I am trying to find a relationship between gender and the anemia or hemoglobin level. Okay, so at this point, is there any relationship? It means what? Right now I'm measuring the exposure, that is gender, and also right at the same point I'm measuring the hemoglobin level. This is called the cross-sectional analytical study. Okay, coming back to our example, I can take in cross-sectional analytical studies, okay, I can take all TB patients or anybody with in a community, okay, 1,000 people. Out of them, some may have peripheral neuritis, some may not have. At this point, anybody is taking INH or not. Okay, isn't. At the same time, not asking about in last 1 year you're taking. If I ask the question in last 1 year, have you ever taken, this means it becomes a case control study. Okay, at present, whether you are having that particular exposure or not, that becomes a cross-sectional analytical studies. There are issues with cross-sectional analytical studies. For example, I'll give another example for the cross-sectional analytical studies. You want to find out, is there any relationship between being obese and having knee pain? Okay, so obesity or sedentary lifestyle and having obesity and the knee pain. Okay, so what leads to which one is the exposure and which one is the outcome? Okay, so usually we think because of obesity it leads to knee pain, right? So it may be the other way is also possible, because he has injured his knee, he is not going for physical activity. That also has led to the weight gain. If you in a cross-sectional study, if you try to relate, if you find an association between knee pain and the obesity or weight gain, it's difficult to say which one came first. Is it knee pain came first, then it lead to, because he's not playing or he's not doing physical activity, he gained weight, or he had gained weight, then only the knee pain appeared. That we will not be able to find out unless it is a follow-up study. Because you're measuring both at the same point of time, we don't know which one came first. Okay, so this is the problem with the cross-sectional analytical studies. By logic means what? Someone has to take INH for a certain period of time, then only he can develop peripheral neuritis. Similarly, someone has to smoke for a certain period of time, then only they'll develop the lung cancer. That means what? The exposure has to happen first. Okay, then the outcome happens. So this is called the temporality or temporal association. Okay, in studies we should be able to prove that the exposure happened first, then the outcome happens. So this temporality cannot be proved in cross-sectional analytical studies. It is cross-sectional. That means what? You are measuring exposure and outcome at the same point of time. Many times inference will be wrong using cross-sectional studies. That's why the articles gets rejected. Once you submit for thesis, for your approval, for review, or you submit for publications, when you say INH intake led to this one, that means what? You should have a follow-up design. That means a cohort or a case control which evaluated the past exposure. If you're not using cohort or case control or RCT, from cross-sectional studies, we cannot establish which one came first, exposure or the outcome. That's the problem with the cross-sectional studies. Okay. So this is in nutshell about how you identify each study design. So the first thing is distinguish as an experimental study or you are doing observation study. within observational, whether you have a single group, you want to describe what is happening in that group, or you want to compare between 2 groups or 3 groups, it becomes analytical study. When you're comparing between 3 groups, again decide on, okay, whether you're doing a cohort study or it's a case control study where you start with your outcomes or your groups are based on outcomes, or it's a crossing study. I'm not bothered about exposure or outcome, but I'm measuring both at the same point of time. So this is the broad classification of the study designs. Okay. So all the study designs we discussed about is whether individual person is taking INH, whether that person is developing peripheral neuritis or not. There are something called ecological studies. I think during COVID, everybody read about the BCG. Okay. In a country where the BCG coverage is more, whether COVID is high or not. Okay, this is called a example. It's a population as observations. Okay, I don't know whether somebody usually got BCG and he got COVID or not, but I have the aggregate data. In this population, this country, BCG coverage is good. In this population, the COVID is less. Again, these are called ecological studies, and these are helpful to generate hypotheses, but we cannot conclude based on the ecological studies. Okay, so this is the hierarchy. So basically, descriptive studies, for example, one group, what happens in one group. Okay, so let us say peripheral neuritis, it's the 20% people develop peripheral neuritis. I can see more common in male. That means what? Okay, so if you take higher dose or if it is male, they're getting more peripheral neuritis. If you want to prove this thing, again, you have to go for analytical study designs. Okay. So case reports, case series, ecological studies, even crossing studies are good to generate hypotheses. This will raise doubts. This will create doubts in mind. Okay, this factor may be related. We are not sure. Okay, this may be related to a particular outcome. Then you design a good analytical studies in terms of case control or cohort. If possible, if it is not unethical, go for a randomized controls to establish the exposure and outcome. Okay, so this is the usual startup. Or some people, if you are working with a guide who has already done observation studies, you can go for directly to prove the hypothesis. You can go directly for the randomized control trials. So this is again coming back. So analytical studies, cross-section is a snapshot. At this point of time, okay, what is the relationship between exposure and outcome? But as I already said, we cannot comment on which is the cause and which is the effect. Okay, that's there. Cohort is...
no, the speaker is not working, or is it?
Please mute your audios. Please, I request all the participants to mute your audios.
Shall I continue, Dr.
Yeah, please go ahead, sir.
Okay. So in cohort and case control, this because the temporality can be established, and you can see, you can very well infer what is the cause and effect relation. We call as the exposure outcome. That relationship can be inferred in the case control and cohort. So this is an important distinction whether you want to do a case control study or a cohort study or crossing study. So this is a pictorial representation of this one. So as I already said, cohort study, you assemble the groups based on your exposure, smokers, non-smokers, or patients taking with a particular drug, patient not taking the particular drug, or dosage of 10 milligram versus 20 milligram. These are based on exposure. Then you follow them up and you see the outcome, whether whatever is the blood levels of the drugs or adverse effects of drugs. If you conduct a study like this, it becomes a cohort study. Okay. Then in case control study, you do the reverse one. You have the adverse effects or whatever the other outcomes. Then you go back and see what is the kind of exposure between the two groups. Okay. In crossing study, both exposure and outcome are measured at the same point of time that we already discussed. What are case report and case series? Case report is the reporting of a medical oddity. Okay, I will not report a case report of rifampicin or any other tuberculosis drug causing a jaundice or hepatotoxicity. It is very well known. But if it is a medical oddity, if it is not, it's a new adverse effect, it is not reported in medical literature. Okay, so it's either a common presentation of an uncommon disease or uncommon presentation of a common disease. Okay, then we'll present a case report. So we have seen 1 or 2 case reports on the complete cure of HIV, right? HIV/AIDS. Okay, so till now we don't have many studies on the patients completely cured of HIV and AIDS. If there is one patient who has been completely cured, okay, it's an oddity, it's a new thing. Okay, I want to present as a case report. We will not see case report of one pulmonary tuberculosis patient treated. No, we will not do a case report on that one. Okay, it's basically a medical oddity. Okay, Then case series is description of a similar case, a serious case of interest. Okay, I have seen in our institute or in India, there are 5 cases of HIV that has been cured. Okay, then what is common in these 5 cases? These are all males, these are all diagnosed early, the CD4 counts are this much. Okay, there will be some similarity which helps us to generate some hypothesis. These are called case series. Okay, so these are again coming under the descriptive studies, and there is no hypothesis in these study designs to test it. So this often generates hypothesis or the relationship questions that can be proven or disproven in the analytical studies or a better study designs. So cohort study, as I already told, it can start with exposed people, non-exposed people. These are the 2 groups. The groups are based on the exposure. It could be the drug dosages or different types of drugs, or could be any intervention. Okay, this is called the cohort. Okay, right. So the advantage of cohort is you can study multiple outcomes of a single exposure. For example, I'm talking about INH. I can talk about the drug levels. I can talk about the adverse effects, or I can take about the how the bacteria reacts to the INH, all those things. Okay, so multiple outcomes of a single exposure. For example, if I study the tobacco, people using tobacco, and obviously this exposure and outcome, the primary outcome I'm looking at is tobacco and the incidence of myocardial infarction. Okay, my primary outcome is myocardial infarction, but tobacco is related to many other diseases. I can talk about gastritis, I can talk about the cancers. Okay, so one exposure tobacco, the other group is what? Tobacco, people who are not using tobacco. I can follow them up, I can study multiple outcomes. That's the advantage of the cohort study, right? So it is not necessarily the cohort has to start with 2 groups, exposed and not exposed. Okay, that means tobacco users, not tobacco users, people who are taking INH, not taking INH. Okay, I can have a defined population. Okay, let me take all patients who are taking ATT drugs. Within that, some people may be taking INH, some people may be taking rifampicin. Okay, it could be like I can take a group of hypertensive patients. Some people may be taking atenolol, some people taking amlodipine. Okay, then multiple exposures can be studied along with multiple outcomes. So it's not necessary you have to define 2 groups, but this defined population should have the flexibility to define multiple groups. You take a group of hypertensive patients, obviously your primary research question is atenolol compared with any other diuretic. Okay, what is the BP control? But in the same thing, some people may be taking not only thiazide, some people may be taking about the this thing also drugs, right? So you can have multiple exposures also possible. You take a group, if you take a defined population, instead of having only 2 groups of atenolol versus the thiazide group or the diuretic group. Okay, so this kind of study is also possible. It's not only you have to take only 2 groups, exposed, not exposed, but you have to take a defined population, study population. Within that, you can study multiple exposures as well. Obviously, once you follow up, you can study multiple outcomes. If you take antihypertensive drugs, their BP control, their adverse effects, or non-hypertensive benefits, whatever it is. Okay, so you can study multiple outcomes, right? So again, within cohort study, this is about how you assemble the cohort. Either you go for 2 groups, exposed, not exposed, or you take a group of your defined population, and then you can define groups, multiple groups. The other way is whether it's a prospective cohort study, okay, or a retrospective, or it's something called as ambivalence or ambispective. Okay, prospective cohort study means what? So it's in calendar time. Okay, right now I'm going to assemble 2 groups, which is exposed or not exposed. I'm going to follow them up. Okay, so and follow them up for an outcome. Okay, this becomes a prospective cohort study. In INH example, I'll take a group of people who are going to take INH, and there's another group of people who are not taking INH. I'm going to follow them for the next 6 months, and I'll measure whether they have peripheral neuritis or not. This becomes a proper prospective cohort study, because in future, from now on only, I'm going to see whether this patient is taking INH or not. The other group is not taking INH, and I'm going to follow them up till they develop whether they develop peripheral neuritis or not. That becomes a classic prospective cohort study. Okay. In some of times, for example, the exposure need not start after your study. Okay. For example, this being a prospective study, I'm going to take new tuberculosis patients who are going to put on treatment. After that, only INH will start. In some other studies, the person is already a smoker. Okay, the exposure has happened before itself. That's fine. But now I'm going to start the study. At present, they don't have any of the cancer or something. I'll constitute two groups. Those who are smokers for last 2 or 3 years, that's one group. There's another group, there is no the non-smokers, but at the starting of the study, both do not have cancer. I'm going to follow them up every 1 year till 10 years. Okay, that means what? At the start of the study, I know there's some people, one group is having exposure, another group is not having exposure. I'm going to follow them up. The frequency of follow-up depends upon the outcome. Okay, if you want to do a cohort study on doing using anesthetic agent, you'll be following up the patient for every minute or every 5 minutes, 30 minutes, half an hour. If I'm working for cancer, there is no point in testing every half an hour, right? So I'll be the frequency of follow depends upon the outcome. For cancer studies, I can follow them every 1 year. Okay, so these kind of these are two ways we can do a prospective cohort study. Either the exposure has already happened, but outcome has not happened. Still, prospectively, I'll follow them for the outcome. Or other way of doing a prospective cohort study is both exposure and the non-exposed will start after your study. Okay, then you follow them for the disease outcome. Cohort studies, everything is over. Okay, the difficulty for any lecturer is to differentiate the retrospective cohort study and the case control study. Okay, so in retrospective cohort study, what I will do is, okay, within the a particular program or this thing, so already the disease also happened, exposure also happened. Okay, but I'm going back in time. Okay, I'll take last year cohort of tuberculosis patients who has taken a INH. I assume there is another cohort of TB patients or some other patients who are not taken INH. Okay, I'll go back in time. I'll go back to 2019. I will start the cohort. One group who has taken INH, other people who have not taken INH. But I'll follow them up back in time. I'll go to till June or July 2019 and see. Okay, whether people who are taken INH had a higher incidence of peripheral neuritis compared with those who did not take INH. This becomes a retrospective cohort study. This is not a case control study because my groups are not based on peripheral neuritis or not. My groups still, it's a cohort study. I go back in time in 2019. I'm going to make two groups. One group is those who taken INH, the other group has not taken INH. So even it's a retrospective study. I'm going back in time. My direction of inquiry is based on my exposure. Okay, my groups are based on exposure and follow them up in time. Okay, maybe till 2019, June or July 2019. This becomes a retrospective cohort study. Okay, and there are something called ambidirectional this thing cohort studies. Something exposure has happened in some way we can say this is something has exposure has happened before, but still I will continue for the outcome. Okay, these studies are rare, ambispective. It's better to go for a prospective cohort study where you have the control about the measurements. Okay, your outcome is something like hemoglobin level. If you leave it to retrospective part, in last year, they would have used different methods to measure hemoglobin. Different people would have been involved. It will lead to bias. If the prospective study, you can standardize it, how the variables can be collected, who will collect it, what kind of test will be done, how it will be documented. Okay, it's always good to go for a prospective study. But again, if time is short, if already good information is available in even records, your lab is excellent, the documentation is excellent, even in records, I can extract the data, then you can go for a retrospective design. Right. So advantages of cohort studies, I think cohort studies itself will take 1 hour time, but I'll simply say what are the advantages of cohort studies. It can establish the population-based incidence. That means it's a population-based or something. Even anything, if you want to calculate incidence of adverse effects of a particular drug, it's good to go for a cohort study, it's a follow-up study. Okay. So relative risk or risk ratio, any of the articles, even in RCTs or this thing, the best estimate could be the risk ratio, not the odds ratio. Okay, so these risk ratios are the direct or preferred measures in the cohort studies. The risk ratio is nothing but in one group, the risk of developing a peripheral neuritis in INH group compared with risk of developing peripheral neuritis in the group which is not taking INH. It's basically comparison of risk or ratio of two risk. We call it the relative risk or the risk ratio. Okay, or incidence, comparison of incidence of the outcome in between the two groups. This is again direct measure, very useful measures. Okay, if somebody is taking INH, is 2 times at more risk of, or the likelihood of developing peripheral neuritis is 2 times or 3 times higher in people who are taking INH compared with who are not taking INH. It gives a direct estimate of the risk. Okay, the magnitude of the risk. Okay, it's useful to examine rare exposures. I think we have to read more articles or have an exposure to journal clubs. Okay, so in terms of rare exposures, if you do a case control study, you may not pick up the rare exposure. Okay, but if it is a cohort study, you can include them as one group. Okay, for example, exposure to radiation. Okay, that group can be kept as a separate group, then you can follow that group compared with a group which is not exposed to the radiation. Okay, so temporal relationship can be inferred. This is very the best design for the temporal relationship is the cohort study in the RCT, because when you start the study, nobody will have an outcome. That means what? At the starting of the study, the outcome has not happened. You have two groups, one is exposed, other one is exposed. Then you follow them up. What is made sure is the exposure happens first, you are following them up, then only the outcome happens. This is called the temporality. This is very, very important in assessing the causality. That means attributing an outcome to a particular exposure. If you want to say this adverse effect is because of this drug, there are multiple criteria, but one of the criteria is temporality. Okay, so that means you should have taken the drug for at least 3 months. Then only we can attribute this to the particular the drug to the outcome. Okay. So multiple outcomes can be studied because you follow up a cohort, multiple outcomes can be studied that we are already listing. There is something called time to event analysis. We call Kaplan-Meier survival analysis. This time to event analysis is possible only in cohort studies. Okay, you have the time this fellow is followed for 3 months, he had an event or not. Somebody is followed for 6 months, he has an event or not. So this kind of survival analysis is possible only in the cohort studies, not in case control studies. Can be used where randomization is not possible. Okay, sometimes randomization is unethical. For example, in pregnancy, you want to see the effect of diazepam or some other drugs, which is not usually indicated. You cannot randomize pregnant women to take diazepam or some other sedatives, whatever it is. I'm not sure. I'm not very strong in the pharmacology subject, but I'm giving an example. Where randomization is unethical, we cannot do it. But you can always have a cohort. Some people may have prescribed diazepam for that. Okay, you can do a retrospective cohort study. Okay, people, the pregnant women who have been taken diazepam in last year. Okay, so what happened compared to pregnant women who did not take diazepam? This is a retrospective cohort study is possible. Okay, so again, in during life-saving procedures, even emergency EMS department, emergency medical department, where during life-saving this thing we cannot do a randomization, we cannot ask for a consent. Okay, where randomization is not possible, we can do a cohort study. At this life-saving procedure we did for this group of patients. For some other patients, for some reason we did not do it. Can we compare the outcomes between the groups? Again, it's a cohort which received a particular life-saving procedure compared with another cohort which received a different life-saving procedure, where a randomization is not possible because the life-saving procedure. Okay, so those kind of things, cohort studies come handy, very handy. This thing. Okay. And selection informed bias are addressed. I think we do not take much. Information bias leads to, it talks about in a prospective study, you have control. Okay, cohort study. I can measure the way I want the exposure. I need the calibration of the instrument and all those things. Outcome also, only one person has to measure and how to measure and all those controls are there in a cohort study. But in a case control study, exposure has happened in the past. We have to rely on, I took INH for 3 months. No, I took for 6 months. We don't know whether he has taken really how long, what dosage is taken. Those kind of biases can creep in the case control studies. But if it's a prospective cohort studies, we can collect it directly with the patient or whatever the method. So you have more control over the biases, the information you collect for the particular studies. Okay. So disadvantages of cohort studies. So it's lengthy and expensive, depends upon, for example, cancer and all, you have to follow the patient for 10, 15 years. There will be huge loss to follow up. It will be very expensive to follow up these patients. Okay. And if you want to study a rare disease like cancer is not common. Okay, if you say incidence of cancer is like 5 per 1 lakh. If you want 5 cancer patients, you have to follow up 1 lakh study participants to end up having 5 cancer patients. The 5 cancer patients may be a smaller sample size. If you want at least 100 cases, cancer cases, then you have to follow like 10 lakh or 100 lakh of participants. So this becomes very expensive. And it's not suitable for this long latency. Okay, 10 years, 15 years follow-up and all not possible. Okay, again, non-response, loss to follow-up is very common in long-term cohort studies. These are some of the problems. But compared to a case control study, for analysis purpose, for inference purpose, cohort studies are much better than the other study designs. So case control study, I already explained, you start with the outcome, you define the groups based on your outcome, maybe lung cancer, no cancer, or peripheral neuritis, or those who are having glycemic control compared with we don't have glycemic control. Go back and see what kind of drugs they have, what kind of exposure they had. Okay, this is the case control studies. So it's cheap, easy, because already outcome has happened. Okay, you assemble two groups based on your outcome, just ask, interview them what happened in the past. It's relatively quick compared with the cohort studies. The advantage is rare diseases. You have a rare syndrome. Okay, if you follow up the 1 lakh people, you get only 5 in cohort study. But you are in a specialized institute where you can see this particular rare cases of whatever the syndromes, then you can quickly assemble a case control study and you can look back what are the exposures, family history, or whatever it is. Okay, so this can be done in the case control design. So disadvantages, again, it is subject to bias. Okay, if you ask the person 2 years back whether you took the drug or not, it's difficult to recall what kind of exposures they had in the past. Okay, it's called the recall limitation. And the other thing is the cases who are having some disease, they will recall differently compared to the controls who do not have the disease. Okay, those who have peripheral immunities, they will why I'm having this problem. He will remember better, or you will differential recall compared to did not have a disease. Okay, so sometimes temporal relationship is not clear, okay, because of all these biases, but still it is better compared to a cross-sectional studies. Okay, multiple outcomes cannot be studied because we start the group with outcome, so we cannot have multiple outcomes cannot be studied, but we can study multiple exposures. These are the disadvantages or pros and cons of the case control studies. So cross-sectional studies, I already explained, it could be descriptive. You are looking at one group, we call it the prevalence studies. Okay, in this group of diabetic patients, what is the prevalence of retinopathy? At this given point of time, out of 500 people, 100 people have retinopathy or neuropathy, whatever it is. It's called prevalence or distribution. In this group, 70% are having this problem, 30% are having this problem, and 70% are taking insulin, 30% are on OHA, something like this. This is about the descriptive cross studies. Other one is analytical, where you compare some parameter between two or more groups. Okay, as we already discussed, temporalization is not possible, but it has its own applications for screening purposes. Okay, we'll leave that. Then I'll come to this important slide of measure of association. In cohort studies, what you'll end up in calculating. Okay, in cohort studies, you follow 2 groups or 3 groups, and what will interest is whether the outcome, it could be adverse effect or mortality or any glycemic control. Okay, compared to other group, how the exposure group is doing. Okay, in the group which is taking INH, okay, what is the incidence of peripheral immunities compared with other group which is not taking INH? Okay, this comparison of incidence is called the risk ratio or relative risk. When you're having time to event analysis, you're calculating incidence rates, you're following up patients, that becomes a rate ratio. There is something called hazard ratio. You can also calculate odds ratio in cohort studies. Again, it's something called attributable risk, population attributable risk. All these things can be calculated in cohort studies. Okay, so cohort studies and RCTs are exactly same except only one difference. In cohort studies also, we start with exposure and more than one group, there is a comparison group and follow them till the outcome, mortality or adverse effect. In RCTs also, we do the same thing. We have an exposure and there is a group which takes a placebo or a standard arm. The other group is the new group, the new drug. That is called exposure, right? You follow them up with the outcome. The only difference between a cohort and RCT is the exposure is not assigned by the investigator in a cohort study. Something is naturally happening. Some people are smokers. In RCT, the investigator is doing the experiment. Other than that, RCT and cohorts are same. And it's a better study designs because you can calculate so many things, risk ratio, okay, number needed to treat, hazard ratios, attributable risk, each one has its significance. I think you have to read in detail about these measures. Okay, and you have to clear about what measure you want in your study. Okay, so cohort studies can give a lot of options. Case control studies can give, it cannot give incidence. Okay, because starting with the disease, we can simply get called something called odds ratio, which is an indirect way of telling risk ratio. Okay, so we can derive risk ratio, but we cannot directly calculate risk ratio from the case control studies. What you ultimately end up in getting is the odds ratio. So cross-section studies, we can calculate odds ratio. We can calculate something called prevalence ratio. The prevalence of diabetes among males is this much compared with the prevalence of diabetes among the females, or the prevalence of obesity or something. We can say it's a prevalence. It is not incident because cross-section studies we do not do follow. At this point of time, in one group, this is the prevalence compared to the other group. It's called the prevalence ratio. Or we can calculate something called the prevalence odds ratio, cross-sectional odds ratio that we can calculate. So again, it requires some more reading, not only reading, and you can look for a lot of YouTube videos or read some articles, journal club articles, discuss it. Okay, that's the better way to understand these measures rather than a 45-minute lecture on the and the study design. It's basically a sensitizing session for the postgraduates. So ecological studies, I think we discussed already. Here we take up aggregate data. Okay, so what is the weekend sale of alcohol in a particular district and number of accidents? It doesn't mean people who take buy alcohol end up in accident. We don't have evidence for that, but it grossly tells okay something wrong. If this alcohol sales goes up, there is a RTA also going up. Then I will design a better study design. Individuals, based on individuals, whether somebody consuming alcohol, whether he is ending up in accident, this becomes a cohort study. Or I'll take all road traffic accidents and people without a road traffic accident. I'll see among road traffic accidents what percentage is consumed alcohol. Okay, it becomes a case control study. Okay, so ecological studies helps us to generate hypotheses which can be answered in a better study designs or analytical study designs. So terminologies to remember: descriptive study describes a particular condition in a one group. Analytical studies, it looks for risk factors, comparison of factors, whether smoking is related, whether INH intake is related to the adverse effect or not. Okay. A cross-section study could be either descriptive or analytical depending on how many groups you are dealing with. If it is one group, we call it a cross-sectional descriptive study. If you have more than one group, 2 or 3 groups or more groups, we call it a comparative study, cross-sectional comparative analytical study. A longitudinal study could be descriptive analytical. If you are following only one group of patients, we take only INH patient, I'm not doing another group, and see at 1 month what percentage develop peripheral neuritis, at 2 months what percentage, it becomes a longitudinal descriptive. You do not have a comparison group. But instead of that, you take INH group compared with those who are not INH, then it becomes analytical group. A longitudinal analytical study is a cohort study. Okay, a cohort study is a longitudinal analytical. Longitudinal means follow. In cohort study, there is a follow, and a cohort study also has 2 groups, exposed or not exposed, becomes a longitudinal analytical study. Whether you call it a longitudinal analytical study or you call it a cohort study, it means the same. Okay, there are other study designs. It could be observational, before, after, or pre-post study design. These are again observational. Okay, you can say pre-menopausal, what is the heart rate variability? After menopause, you are not doing any intervention there. It becomes observational. It's called pre-post observational designs. There are diagnostic validity studies. They're having screening tests and you have a gold standard you are comparing. Again, these are comparative or analytical study designs. There are other designs, nested case control or case cohort. I think this requires a separate session. Okay, just to sensitize, there are other study designs available. Case crossover studies, all those things. Okay, so sorry for exceeding the time. I'll quickly take through 1 or 2 examples. So a study was conducted to measure the bilirubin levels at the time of admission among ischemic stroke patients. The study concluded that 60% patients had elevated bilirubin level. The study population is what? Ischemic stroke patients. What I'm measuring is at the time of admission, I'm measuring bilirubin level. Based on bilirubin level, I'm classifying them into elevated or normal. So this design is what is the study design? So this is definitely only one group is involved. Okay, so it's only one group is involved. So it's a descriptive study. I did not induce stroke or I did not elevate the bilirubin level. I'm not totally, I'm simply observing what is happening in this patient. It becomes observational. Within observational, there is no comparison group. It's a single group. It becomes a cross-sectional descriptive study. Okay, a similar condition, but at the time of admission among stroke patients with or without diabetes. Okay, here comes, I'm not doing any experiment. So it becomes observational. Within observational, I can see 2 groups, with and without diabetes. That means what? It becomes a comparative study. So diabetes with or without. Okay, again, the outcome is bilirubin and exposure is something like diabetes. I am measuring both at the same point of time. It becomes a cross-sectional comparative study or analytical study. What I'm doing is simply comparing bilirubin between diabetic and non-diabetic. I'm not following it up. I'm not going but asking what about the diabetes control or bilirubin level before. So at this point of time, I'm taking 2 groups, diabetes, non-diabetes. I'm comparing serum bilirubin. It becomes a cross-sectional analytical design. Okay. So I think I'll take example 3 and I'll stop it. Okay. A researcher wanted to study whether childhood exposure to radiation, X-ray exposure, childhood exposure, okay, is related to thyroid cancer. So the research question is what? Whether exposure to radiation at childhood is related to, has something to do with the development of cancer or not. That's my research question. How I'm designing the study? I'm recruiting 100 patients with thyroid cancer and 100 normal people. That means what? My exposure is exposure to the X-ray and outcome is thyroid cancer. My groups are based on cancer. That means what? I am designing the study. I am constituting the groups based on my outcome. That means it's a case control study. A group with cancer outcome, a group without cancer. I'm going back in both the groups history of exposure to radiation childhood. That means I'm going back during your childhood whether you were exposed to X-ray or not. So this becomes a case control study. Okay, I can share the slides and you can go through the rest of the examples. I can take any questions right now. Sorry for exceeding the time.
Yeah, thank you, Dr. Palnivel. So we come to the end of the observational study designs
I can see a
session.
lot of questions.
Yes. So there are a few questions which I'll just read it for you.
Yes,
first question, sir, is please explain with example case cohort study.
So case cohort and nested case control. These are all called hybrid designs. Okay. So case cohort and nested case control similar, only one difference. Okay, it's basically cohort designs. Okay, you follow up a large group of people. For example, you collected you want to study between the lead level, the blood lead level and development of some cancer. Okay, so the exposure is the serum lead level and outcome is the cancer. Okay, so I collect the blood samples at the baseline for 10,000 individuals. I'm storing these blood samples. Okay, ideally I should measure the exposure level for all these 10,000. Okay, but I don't have that much cost. It's very costly. Okay, I'm not doing testing for all these 10,000 samples, but I'm collecting and keeping it. Okay, then I'm following this cohort. Okay, then for example for 10 years. So this is a cohort study and some people develop the cancer. Okay, so for each cancer patient, for example, out of 10,000, 100 developed cancer, I can convert this study into a case control design. Actually, I constitute a cohort, 10,000 people. I have the baseline lead level. That means I have not done the test, but I have the samples for them. Okay, I'm following for 10 years. Out of that, 100 people develop the cancer cases. For these 100 cases, I can choose 100 controls. Okay, I can convert it to case instead of testing 100 cases means what? Remaining 9,900 people who do not have the cancer. I'm not going to test the blood samples for lead for all these 10,000 people. Instead of spending money for 10,000 samples, I will end up spending only for 100 cases. What was their blood levels 10 years before? And I can choose 100 controls and I can test only for these 100 controls and 100 cases. That saves me a lot of money. This design is called hybrid designs. The only difference between nested case control and case cohort is when will you choose the control? I have got 100 cases. Whenever a case happens, a case can happen at the follow-up of 1 year or 2 year, 3 year. Whenever a case happens, for example, at the end of 1 year, I got a case of cancer. At the same time, I choose a control that becomes a nested case control study. Instead of that, I'm going back to the base population. I can choose 100 controls at the end of the study. This becomes a case cohort study. That's the only difference.
Yeah, thank you. One more question. Difference between retrospective cohort study and case control study. You did mention it. You can just maybe summarize it again. Maybe often people confuse
case control, the basic principles doesn't change. Okay, so case control starts with the groups are based on your outcome, and the cohort, being a cohort, the groups are based on your the exposure. Okay, I can give an example of the same example I'll give, or so I can take this. I'll take this example of peripheral neuritis only. Okay, in typical case control, what will you do for peripheral neuritis and INH? You want to study the relation between INH and peripheral neuritis. Okay, in typical case control, what will you do? So your groups are based on what? Your study will start with those patients with peripheral neuritis, one group, 100 patients with peripheral neuritis, and 100 people. It could be healthy population without peripheral neuritis, and you go back and ask them whether you taken INH or not. The study starts with peripheral neuritis in a case control study. Okay, in a retrospective cohort, both exposure also happen and outcome also happen, but your study will not start with peripheral neuritis. You go back in time. For example, you go back to 2019 January. You are not trying to find out who had peripheral neuritis. What you start the study is with, you start the study with, okay, I will take 100 patients who have taken INH. and I'll take another 100 patients who are not taken INH, and I'll simply follow them in time. Okay. Out of people who undertaken INH 100 people, how many develop the peripheral neuritis? I'm not starting the study with peripheral neuritis. I'm starting the study with my exposure, that is INH compared with non-exposed. Okay. The only difference between prospective and retrospective is prospective is from now on you will follow the patients, but in retrospective both has happened, but still you start with the exposure and you try to find what happened to those patients in the past. Okay. So the difference is how you start the study, whether you're starting with outcome or you're starting the study with the exposure. The basic principles of cohort and case control still applies to the retrospective cohort and the case control. In this situation, we can either do case control or cohort, but as I already told you, in case control, the outcome, the measure of function is odds ratio, which is difficult to interpret compared to relative risk. Because in case control also, for example, right now you start peripheral neuritis patients, you go back and see the records, or you ask them whether they taken INH or not. Or you have the records, you start with INH group and no INH group and follow them in records, how many develop peripheral neuritis. In retrospective cohort study, the outcome you'll get, the measure of function is relative risk, which is easy to interpret compared to odds ratio. In a scenario, whether there is a possibility, you can do either case control or retrospective cohort. I will go for retrospective cohort because retrospective cohort, I can get a relative risk, which is easy to interpret, which is a direct measure rather than a odds ratio. Okay.
Yeah. Thank you, Dr. Pandigan, for that. What is the difference between internal and external cohort?
So internal and external cohort,
We have something like that.
Less used. I think I have to check back and
because even I've not heard such thing, but
yes.
Okay.
So internal and external cohorts, sometimes they go for internal and external comparisons. You have an exposed group tobacco users and you compare the different population for an unexposed group. We call it external comparisons or something like historical control, something like that. I'm not very often seeing this internal and external cohort. I'm not sure about this one. Sorry.
Yes. So then there's one more question about, is the sample size calculation different for the case control cohort and cross-sectional studies, or is the same principle applied?
Yes. If you look at the sample size calculation softwares, the cross-sectional analytical cohort and RCT, for example, if you look at OpenAP, okay, this will have the same interface, the same tab you can use for calculating sample size. Case control, I already said cohort and RCTs are same because it starts with exposure and you wait for the outcome. Okay, in a new drug and other drug, what percentage will be the mortality you want to compare. In cohort also, you can use the same thing. In exposed, non-exposed group, what is the outcome? In cross-section analytical also somewhat. Okay, there are two groups, what are the outcome? Only the case control is different. In case control, the whole inquiry is reverse. You start with outcome. In outcome group, what percentage are exposed compared to the non-diseased group? Okay, so the sample size calculation for case control is different. You are not studying. If I take INH, what is the risk of developing peripheral neuritis? That question you are not answering in case control study. If I have peripheral neuritis, that's the outcome. What percentage of peripheral neuritis patient would have taken INH? Okay, the direction of inquiry is different. So the sample size also is different for the case control studies. You will try to find out how many cases I need to conduct a case control study. Okay, and how many controls I need to conduct a case control study. That's what the sample size, aim of samples in case control studies. But in cohort or RCTs, the aim is how many exposed individuals and how many unexposed individuals I need to study in order to answer this research question. Okay, in RCT or a cohort. So I think I can club a cohort, cross-sectional analytical and RCTs in one side. The samples calculation is more or less similar and case control is similar. Case control is different. The longitudinal study is any study where it includes follow. It's a longitudinal study. It's not a standalone study design. A longitudinal study design can be a descriptive. You follow one group, what happens at 1 hour, 2 hour, 3 hours. It's a longitudinal study, descriptive study. A cohort study is a descriptive. You are going to follow up the patients of smokers or non-smokers. An RCT is a follow-up study. You do your RCT, you give a new drug. You're asking both the groups to come after 3 months, every 3 months. Again, these are all examples of longitudinal study. There is no standalone design for longitudinal, but this RCTs, cohort, all these things can be longitudinal studies. Right.
Thank you, Dr. Palnivel. Any other questions from the participants with respect to this session or even any of the earlier sessions? You can ask. Dr. Smitha, are you there? Okay, no problem. So Dr. Palnivel is there, even and I'm there, and if Dr. Jamna Rani is there, Dr. Subro, they can also answer the questions. So some earlier questions were asked. Maybe I'll just read out those questions. In a multi-centric study, should the ethical committee permission be taken from all centers for a questionnaire-based study? So, yeah, Dr. I'll just share the screen so that you could. So for a multi-centric study, should ethical committee permission be taken from all centers? Well, the answer to that question is that as of now, for multi-centric studies, even though there may be a single central ethics committee, they would require individual local ethics committee approvals also. So it's not that one committee can give approval for all the centers. There needs to be individual local committee approvals. However, if it is a low risk study, there is a proposal right now that is not yet formalized from the ICMR to make it such that for all low risk studies, including questionnaire based studies, a single approval from a common center which looks after all the centers ethical aspects will be approving the project. But this is not yet formalized. It was in draft stage. It had come before the pandemic. So maybe in a couple of years, it would become the law where we have this kind of setup. Which studies do not require ethical clearance? I think this was told in the morning. And again, we'll share the ICMR document, which gives this in very clear terms. For a KAP study in COVID patients at community level, should we get approval from any government personnel? Dr. Palnivel, you want to answer this question?
So which one, sir?
For a KAP study in COVID patients at a community level, should we get approval from any government authorities?
So it's mandatory, but giving the COVID going on, anybody visiting the COVID patients is better to get approval or inform the primary health center or the particular district authorities before that. Even the ethics committee asks for these things, whether you inform the state health department about your study. When you go for a community-based study, it's a good practice to get approval.
Yes. Okay, so for an independent researcher, should they approach an independent ethics committee or an institute-based ethics committee? Well, independent ethics committee largely involves giving review approvals for studies of which are mainly the BAB studies, bioavailability bioequivalence studies. They are largely doing in that aspect. So other studies, it is if you're an independent researcher, it is better you try to approach institute-based ethics committee. There is no mandatory guidelines given on this aspect yet, but in general, it's encouraged that you get your approvals from an institute-based ethics committee. And is it not exemption from review for meta-analysis, but still take the clearance? So, okay, meta-analysis, should we go for an ethics committee approval? Yes, meta-analysis, again, it depends on institute to institute. As of now, there is no mandatory guidelines which state that you need to get approval from the ethics committee, because meta-analysis will involve you taking data from a publicly accessible domain. There is the ethical issues involved are less, so even journals do not usually ask ethics committee approvals. But your institute might have a policy saying you should get the approval from the scientific committee. So if that is your institute policy, then you might have to get the scientific committee approval. And if you still want an ethics committee approval, you could send it to ethics committee and ask them to give you exemption from review. They would probably consider this meta-analysis as exempted from review because it's considered as less than minimal risk. And does ICMR suggest any independent ethical committee for independent researcher? To the best of my knowledge, it is not said this way, but Dr. Palnivel, do you want to answer this question?
There are committees which takes money. We have to pay for the ethics meetings, and we can approach that. There are committees existing there. Usually for medical colleges, institutions, I think the research has to be one of the PI there are some regulations. If they are not PI or not even a co-investigator, they will not take up the proposals. And I heard about ICMR as a separate committee for independent researchers. They can approach the ICMR for those kind of approvals. So they can, but they are not meeting very often. I think once in 6 months or once in a year, they take up the proposals where independent researchers do not have an access locally for a ethics approval. So I heard about it, but I'm not sure about this one. I think ma'am can answer the questions.
Yeah, Dr. Melvin, may I?
Yes, please, go ahead.
So yes, the practice of I am talking about the PGI-MER Ethics Committee. So a lot of proposals do approach us medical colleges, especially where they do not have ethics committee. And if we have a separate fee structure, whether it is a pharmaceutical industry or a small CRO, or it is a government organization. So the fee structures are different, but yes, they are actually they have to pay some fee to the ethics committee. Whereas the institution, within the institution, obviously there is no fee.
Yeah. Retrospective observational studies, does it need ethical committee permission? Yeah, any one of you could answer it.
So yes, definitely. The ethics again looks at the anonymity of data and all because it involves records, the patient confidentiality, how the researchers are going to maintain the confidentiality. Okay, so for whether those things, anything again during the session also, ma'am said the committee will decide whether you need a ethics, the patient consent or not. So all retrospective studies also will require it has to go through the ethics committee. Whether waiver of consent or exemption will be decided by the committee. It should not be decided by the researchers ourselves.
Yes, exactly. So as clearly said, it is all studies where you're collecting data, even if it is retrospective, it has to mandatorily undergo an ethical review, and you can send an application for waiver of consent, justifying why you are saying so, and if ethical committee feels it relevant that this can be considered as waiver of consent, then only you could do a study where there is no waiver of, where there is no informed consent requirement. And confidentiality is obviously a very major issue here. So you will have to keep that in mind. So if I don't see any other questions from the audience, so I think uh, people are satisfied with the sessions, hopefully. So to summarize what okay, before I summarize, once again I want to thank Dr. Palnivel for this last session on observational studies. I'm sure it is an eye opener for many of us, because this observational study design is one design that many of us will be using. Okay, I see a lot of clinicians here, so many times you will be using an observational study design, either a cohort study or a cross-sectional study or a case control. One of these invariably you will be using it, or sometimes even a descriptive cross-sectional study. So it's very important that you understand how a observational study design study is done, how it is a protocol is made for an observational study. It's good that you understand these issues very well. So we will be sharing the slides later after the workshop is over. You can go through it. We will also be giving you some study material. So please go through the study material so that you will have a deeper understanding of these topics, concepts. And we will also give you some assignments based on these sessions that we had today. So thank you all for your patient listening, all 4 sessions. We believe that most of you, even though we couldn't see you, you were actively participating and listening to the sessions. So thank you, and we will be giving you the feedback form for today's as well as tomorrow's sessions tomorrow. So tomorrow we'll begin again at 9:30 sharp. So we request all of you to come here at 9:25 so that we will not waste any time and start the sessions right away.
Should say come on time.
Thank you.
Yes. Thank you, Dr. Smita. Thank you, Dr. Palnivel.
Thank you, Dr.
Thank you.
Thank you all.